उत्कलवङ्गा विन्ध्य हिमाचल यमुना गङ्गा उच्चल जलधितरङ्गा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Physician prayer by Dr. Priyadarshini from Salem.
Good evening, sir. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift come from thee, I pray that you give skill to my hand, clear vision to my heart, and strength to my body. I pray that I will always realize that being a physician is a privilege and honor. With the simple faith of a child, I will rely on thee. Amen.
Yes, sir. Thank you. Thank you, Priyadarshini. Good evening to everyone. Today, we are having the South Zonal and South Mid-Zonal API in ICP Masterclass. Today, our chief guest is none other than our Professor Dr. Y.P. Munjal, sir. He is the API Finance Committee Chairman and PR of Director in charge and Post API President and ICP Dean. May I request our chief guest to take over the program and introduce about the topic, that is secrets of living to 100 with the hold in Peri-COVID era. And sir will be introducing the other moderators, Dr. N.P. Singh and Dr. Chris Mathur and Professor Dr. Jyotir Paul. So over to Professor Dr. Y.P. Munjal, sir.
Thank you. You can hear me?
Yes, sir. Yes.
Honorable President Dr. Kamlesh Tiwari.
Sir, one minute, sir. One humble request. One speaker is speaking. Others, if they are in mute mode, there won't be any internet problem at all, sir. Please mute, sir. Yes, sir. Yes, sir. Munjal, sir.
Mr. President Dr. Kamlesh Tiwari, Senior Member Dr. B.B. Thakur, Dean, Indian College of Physicians, Dr. Rajesh Upadhyay, and we are privileged to have Dr. Mohan as one of the panelists for this evening, which is a great honor, and I think the students will also learn a little bit from him. We have other luminaries in Dr. N.P. Singh, who is Professor of and Dean in the SGT Medical College. He is a nephrologist by profession and a very clear and candid personality. We have Dr. Mathur and Dr. Jyotirmay Paul. Dr. Jyotirmay Paul, I think, gave the idea to Dr. Rajesh Upadhyay to start this postgraduate and physicians program, which is a runaway success. My compliments to Dr. Jyotirmay Paul and Dr. Rajesh Upadhyay. Then we have Dr. Girish Mathur. He is the pivot in Rajasthan and is also looking after the swimmer program in Rajasthan. I just have to say one thing. Human desire to live long is innate. But unfortunately, we still have a long way to go to have a mean age of 100 years. But to have a life of 100 years, it is important that we must be healthy, our mind should be clear, and we should be ambulant, because if you are a sick person, then you are a burden on the society. So when you live till 100 years, it has become more pressing following the COVID epidemic. And I think the principles which are enshrined even in Bhagavad Gita, which says, eat sattvic food, that is simple food, exercise every day, keep on doing your karma, try and avoid bad thoughts in your mind, and finally, it goes on to add that do some sort of meditation so that you keep fit. With these few words, I thank Dr. Palniappan for having invited me to this program. I'm really grateful to him. And we have luminaries to moderate this session. Thank you very much. Long live API.
Thank you so much, Dr. Munjal sir. And may I request today's other moderators, Professor Dr. N.P. Singh sir, he's the post API Vice President and ICP Dean. And I'm requesting Dr. N.P. Singh sir to introduce Professor Dr. Raman Puri sir and Dr. S.N. Narsingan sir and Professor Dr. V. Mohan sir. Over to Dr. N.P. Singh sir.
Thank you, Dr. Palniappan. Let me at the outset thank you for having given us a chance to at least be together in this era of COVID, and I think you're doing a great service. And it's my proud privilege first to introduce my moderators. Dr. Puri is a very, very well-known, renowned cardiologist, has been in Apollo Hospital for a long time. He's been spearheading the issues of lipids, and he's been almost dignitaries of all lipid associations of India, and he is a great orator as well. And second is, of course, Dr. Mohan. There's no one in this panel who would not be knowing Dr. Mohan. He's a very renowned diabetologist and has been awarded with various, national awards as well. And also, I have a privilege in inviting the third panelist, and I welcome him as well. And with these few words, I think we are lagging behind the time, and I would request Dr. Jyotimal Paul and others to take over. And again, I would like to thank profusely Dr. Palniappan for having actually collected us together on this platform, and we would go forward with the program. Thank you. Dr. Palniappan, you are muted, so you have to unmute first.
Please.
Can't hear you, Doctor. Yes.
Dr. S.N. Narsingan sir, introduction.
Yeah, Dr. S.N. Narsingan, I welcome you. Of course, Dr. Narsingan has well-known luminary in his field and has been in the field for a very, very long time, and I welcome him as well. Thank you.
Thank you, Dr. N.P. Singh sir. Over to Dr. Greece Mathur. Greece Mathur sir, he will be introducing Dr. Rajesh Upadhyay sir, Dr. Ramakrishnan, and Dr. Prabhagar and Dr. Kumaravel.
Thank you, Dr. Palniappan. for making me part of this very important API masterclass on a very interesting subject, secrets of living to 100 with hold in Peri-COVID era, with galaxy of eminent speakers. It's my proud privilege to introduce Dr. Rajesh Upadhyay, Dean, Indian College of Physicians, and past President API, the brain behind these masterclass, which are being run by various state chapters in the country. Dr. Upadhyay is a renowned gastroenterologist. He is Director and Head Department of Gastroenterology and Hepatology, Max Super Specialty Hospital, New Delhi. Next in line, I will welcome Dr. S. Ramakrishnan. Dr. Ramakrishnan is Professor of Cardiology, All India Institute of Medical Sciences, New Delhi. I welcome Dr. D. Prabhakar. Dr. Prabhakar is Senior Consultant, Interventional Cardiologist, Ashwin Clinic, Dr. Mehtaj Hospital, Apollo Group of Hospitals, Chennai. I welcome Dr. V. Kumar Well. He is a Chief Endocrinologist, Alpha Hospital and Research Center, Madurai. My best wishes for the program. Thank you, Dr. Pandit.
Yeah, thank you very much, my dear Dr. Grace Mathur, sir. May I request Jyotirmay Paul, Professor Jyotirmay Paul, my dear friend, to introduce Dr. S.P.S. Subramaniam. He's a nephrologist, and Dr. Sendil Velan, he's a psychiatrist, and Dr. Meenakshi Sundaram, neurologist, and Meenakshi Bajaj, nutritional specialist. May I request Jyotirmay Paul?
Yes, my regards to Dr. Paliyappan for conducting such a beautiful webinar, and previously I also attended, and first we, on behalf of API, all the members, we are very much thankful to Professor Y.P. Munjal and Dr. Rajesh Upadhyay, who has taken this approach across the country, because in webinar we are restricted to do all the physical problems, and we have two attacks, one attack from the communicable disease, one attack from the non-communicable disease, but we have to survive, we have to overcome, we have to win. So Dr. Paliyappan is giving us impetus how we can overcome all the barriers and we can survive and longer, and this type of program is very much important for the postgraduates, particularly the budding physicians, and they have a ample of opportunity to interact with the specialist of a different domain, which is often not possible in physical class. Only where hardly one or two physician or teacher we can get, but here a galaxy of luminaries they can approach at a time. So I wish success of this program, and I request Dr. Paliyappan, without wasting time, so many students are waiting, you start your program.
Thank you so much, my dear friend, Dr. Jyotirmay Paul. We will move on to today's program, that is secrets of living to 100 with hold, that is hypertension, obesity, dyslipidemia, and diabetes in Peri-COVID era. The main theme of today's panel discussion is prevention of hold, prevention of target organ damage due to hold, management of target organ damage due to hold, and post-target organ damage sequelae management. All the neurologists, nephrologists, cardiologists, lipidologists, diabetologists are there, endocrinologists are there. So they will clarify how to live 100 years. The money is not a problem. So how to live 100 years. So all the tactics they will teach you. And gastroenterologist, Dr. Rajesh Upadhyay sir, and nutritional specialist. To avoiding COVID-19 infection in hold patients, to reduce the morbidity and mortality in COVID-19 patient with hold, post-COVID sequelae with hold management. 2 months after post-COVID sequelae, almost the hold management remains same as non-COVID patient. COVID-19 contacts in family members, it's important. Prophylaxis, what to do, and peri-COVID psychiatric illness in hold patients, and prevention of suicides in hold patients. That also it's very important to increase the longevity, and prevention of suicides, and alcohol, smoking, exercise, sleep, and sex, and work and life imbalance management, gut microbiota. These are all the themes of today's meeting and panel discussion. First, I want to, this is a 2-hour session, so I will be anchoring. All the moderators, Munjal sir, NP Singh sir, and Girish Mathur and Jyotirmay Paul can moderate the session, and they can interact anywhere, anything else. And we'll fire on the dyslipidemia topic first. We request Professor S.N. Narsingan sir, please, how to live 100 in Indian diabetics, sir.
Indian dyslipidemics.
Indian dyslipidemic patients, sir.
Yeah, thank you very much, Dr. Pranayama. Most respected senior members of API and ICP. It's my pleasure to participate in this scientific session, intended mainly for postgraduate students. The question that has been posed to me is that how to live till 100 years in the Peri-COVID era, particularly in those people who are dyslipidemic. I need not emphasize the fact that the dyslipidemia plays an important role. Lipids and lipoproteins are playing an important role, not only in the initiation of atherosclerosis, but also in the progression of atherosclerosis, ending in clinical cardiovascular events. If you recollect the data published by Salim Youssef and his group, a inter-heart study, it was clearly mentioned that the population attributable risk for dyslipidemia is higher when compared to any of the other 8 commonly occurring reversible cardiovascular risk factors, thereby emphasizing the role of ApoB-A1 ratio, which was considered as a parameter in this particular study, was significant in increasing the cardiovascular risk, particularly for myocardial infarction for the first time. It is also seen in many studies that the dyslipidemia is playing a major role in atherosclerosis. Indian dyslipidemic are entirely different when compared to any of the other ethnicities across the globe. We have higher levels of triglyceride, lower levels of HDL cholesterol, and almost normal or slightly increased LDL cholesterol, increased proportion of small dense LDL cholesterol. If you recollect the data published by ICMR in-depth study by Dr. Mohan and his group, really mentioned that about 70% of the patients or population seem to be having a higher levels of low HDL cholesterol, and 12.8% only have the problem of LDL cholesterol. Nearly 29.8% of the people suffer from hypertriglyceridemia. If you take the overall population, nearly about 80% of the population seem to be having one lipid parameter as an abnormal or normal. That is the problem that we have due to maybe a genetic factor which is operating. Of course, the environmental factors need to be blamed, and that has to be corrected properly for us to go further in increasing our longevity. We know that the problem of dyslipidemia is actually triggered by so many factors. The most important factor is the problem of obesity, which is increasing in our country. The problem of so-called metabolic syndrome with the constellation of risk factors are increasing in our country. The problem of diabetes is increasing in our country. So the epidemic of atherosclerotic cardiovascular disease is on the rise. If you just go into the depth of the details of the problem of atherosclerosis occurring in people with the insulin resistance, actually the obesity plays an important role, particularly the abdominal adiposity in association with insulin resistance paves the way for these individuals to accumulate so-called atherogenic dyslipidemia in their vascular territories. Over and above, they have an increased flux of pro-inflammatory and pro-coagulant factors also. These environment probably push these patients for an early atherosclerotic cardiovascular events before they could develop so-called diabetes after many years, maybe 7 years or 10 years later. Before that, they succumb due to abnormal lipids with the pro-inflammatory, pro-coagulant factors which are operating in these individuals with the so-called metabolic syndrome. If you look at those patients with the metabolic syndrome, they need not have even hypertension or even hyperglycemia. They may be having only a small increase in the systolic blood pressure. They may be having a small increase in the fasting blood glucose levels or impaired glucose tolerance and not categorically. I think we should mute people. All others should be muted. Only the person who is talking should get unmuted, please. Only then it is possible to talk. So if you look into those details, we need to probably physical inactivity added to that increased consumption of high-dense calorie foods are responsible for increasing the abdominal adiposity with insulin resistance responsible. So we need to probably modify our lifestyle, increase our physical activity. That is most important as a primary prevention strategy and even the secondary prevention strategy. We need to restrict the diet also, very important. There are a number of dietary modifications which need to be probably modified so that the lipid levels probably will touch the normal values. Over and above, the traditional risk factors will also come down if you modify your dietary composition. So composition, the diet has to be modified. Physical activity has to be encouraged, which will probably prevent the people to develop abdominal adiposity. So you may not develop obesity, you may not develop metabolic syndrome, you may not get into problems of atherosclerotic cardiovascular disease. So therapeutic lifestyle changes is the most important thing that has to be emphasized and re-emphasized. It should start even at the primordial prevention, and that should go on for a primary prevention before the development of risk factors. After the development of risk factors like hypertension, diabetes, or dyslipidemia, it is much more important to emphasize on this role of physical activity, which need to be encouraged, dietary restriction, and avoiding the obesity, maintaining the weight, and good lifestyle habits, including the psychosocial factors, need to be probably concentrated. Avoiding the smoking, reducing alcohol intake, particularly in Caucasians, not in our country. It is not of useful value in our people. We need to actually take into consideration multiple factors which will probably play a role to minimize the so-called risk, not only in the primary prevention strategy points, but also in the secondary prevention strategies to prolong their lives. If somebody adopts this sort of good lifestyle, continuously at the same time concentrating on various parameters, it is possible to prevent the dyslipidemia going up. Why? In people in whom there is an event which had already occurred, we need to probably put them on the good drug, the safe drug, the efficacious drug, statin. Still the best, which prolongs the life. You reduce 1 millimole, 38.7 milligrams of LDL cholesterol. It is possible to get about 20 to 23% risk reduction, and even the mortality reduction has been seen with the introduction of statin. Statin also helps in primary prevention. Number of studies are there to say that it is useful, including your Jupiter study, which had gone to prove that it is useful. Statin and other non-statin drugs have helped these patients to reduce the risk, and many of them are now living for a long period, even after the events. Even the recurrence of events are prevented. The mortality benefit is seen. People are living for a longer period. I think not only primary prevention approach, secondary prevention strategy approach, with the good drug availability of disposable, probably will prolong. I'm sure that will prolong the lives of every individual in our country, provided we adhere to these important information, what I have shared with you, ladies and gentlemen.
Thank you, sir. Thank you very much, sir. Sir, may I request Professor Dr. Ramanpuri, sir, please answer this question, sir. What is the best statin in CKD patient and hepatic dysfunction patient, sir? Over to Ramanpuri, sir. Sir, please unmute, sir.
First of all, I'll thank you for involving in this very important webinar. Regarding statin and CKD and liver dysfunction, use statin of your choice in which you are confident. So there is no specific statin for any particular disorder. Only thing is that in patients with liver dysfunction, only decompensated cirrhosis and acute viral hepatitis, the statin is contraindicated. Otherwise, you can safely use statin. And in patients with fulminant hepatitis, in case of decompensated cirrhosis, if you require statin, better not to use atorvastatin. It's better to use rosuvastatin. Now, coming to the CKD, again, if the GFR is more than 30 ml per minute, you can use statin of your choice. whatever statin you are comfortable with. But once GFR comes down below 30 ml per minute, it is better to avoid rosuvastatin. And if you want to use rosuvastatin, don't go beyond 10 milligram, because it has been seen that the decline in GFR is less with atorvastatin as compared to rosuvastatin. This is based upon Planet 1 and Planet 2 trial. So I think that statins are safe in both these conditions, can be used cautiously, and especially in patients with advanced CKD, one should start with small dose of statin and increase it gradually to get the desirable effect. And only thing is that in CKD, if the patient is on fenofibrate, you should reduce the dose of fenofibrate, because that is a drug which is commonly used. Otherwise, statin can be used whatever you are comfortable with. Thank you.
Thank you, sir. What is your experience regarding the PCSK inhibitor? It's costing around 30,000 rupees, sir. What is the real indication? Where are you using, sir, really in India? PCSK9 inhibitor, sir.
The PCSK9, basically, they are monoclonal antibodies. They bind with circulating PCSK9. And once they bind with PCSK9, PCSK9 cannot bind with LDL receptors. So the patient has more LDL receptor available on hepatic surface to remove LDL cholesterol. And this brings down LDL cholesterol, and that is the mode of action by which PCSK9 inhibitor acts. Now, if you look into all statin trial and statin plus azithromycin trial, for example, IMPROVE-IT trial, still there are 32% of patients in IMPROVE-IT trial. In 7 years' time, they have 32% of fever, despite achieving mean LDL cholesterol of 53 milligram. And even in FOURIER trial, and even in high intensity statin trial also, 70 where you achieve mean LDL cholesterol of 70 milligram, a significant number of patients have residual risk, and this residual risk can be contributed a part by still elevated LDL cholesterol. So using PCSK9 inhibitor in this group of patients, especially those patients with high residual risk of events in near future, like patients with extreme risk group category, which we have published recently, it is better to give PCSK9. PCSK9 brings down LDL cholesterol by around 60%. And in FOURIER trial, the mean LDL cholesterol achieved with the PCSK9 was around 30 milligram, median of 30 milligram. And there are 3 PCSK9 trial in ACS, AVOPAC and AVAS. Here in these studies also, the mean LDL cholesterol achieved is around 30 milligram. So in majority of patients, if you give PCSK9, more than 95% of patients, you can achieve target of less than 50 milligram, as we have recommended in patients with high risk group of patients. So these drugs are only required in those patients in which we are not able to achieve LDL cholesterol target despite high intensity statin plus minus azithromycin, and those patients in which patient doesn't tolerate statin, means statin intolerance patient, where we have no choice other than azithromycin at present, and in case bempedoic acid is available probably by the end of this year or early next year, then in those group of patients, to achieve targets, especially in extreme risk group category A and B, PCSK9 inhibitors are indicated.
Thank you, sir. Over to Dr. Ramakrishnan from AIMS cardiologist. What is the BP target with the target organ damage, without target organ damage, when the age is more than 65, less than 65? Especially the European guideline says less than 140 by 90. That is US guideline says less than 130 by 90. What is your opinion, Dr. Ramakrishnan, my dear friend, Dr. Ramakrishnan, sir? What is the BP target with the target organ damage, without target organ damage, more than 65 years and less than 65 years?
I think, thank you, Dr. Pranayama, for giving me this opportunity. And you are trying to do it like a rapid fire. And I think if we take it as a debate, and this can go on for an hour or so. So possibly the things are so confusing that we don't know what should be the target in hypertension. So I think the most important problem is not what should be the target, but we should take hypertension seriously and should manage it aggressively as much as possible. And in general, by and large, as a rule of the thumb, the younger the patient, you can target it strictly. And the older the patient, it is better to leave it at around 140/90. So what I would say in nutshell as a rapid fire, for everybody, we should keep a target of 140/90. In people who are able to tolerate it less than that, we should keep it around 130/85. And if you are scientifically oriented, there is a something called, it's an era of scores. We always tend to calculate scores, and now you can actually calculate what is known as a sprint score, and from that you can actually target your blood pressure individually. But I think many of the old style physicians will be thinking and laughing at us. What are we creating? This is what we have been doing for ages. From a patient who is coming and sitting in front of me, I can individualize the target from my experience. And that is what we have to do. So we can't have one size fits all. So it has to be individualized, and possibly, I think 140/90 for everybody. And in people who can tolerate it better, 130/85.
Thank you, Ramakrishnan sir. Over to Dr. D. Prabhakar sir. What the office BP, home BP, 24 hours ambulatory BP monitoring with the antihypertensive drug, without antihypertensive drug. This is a very important thing in the record itself, with the antihypertensive drug, without antihypertensive drug, and skipped for abstinence for 2 days, 3 days, like that we have to record, because many times if you reduce the BP by increasing the drugs, they will end up in a hypotension. And duration of abstinence. Which is the best BP monitoring method? Over to Dr. Prabhakar sir. Office BP, home BP, 24 hours BP monitoring.
Thank you, Dr. Paliyappan sir, for the opportunity. I think I will take off from where Dr. Ramakrishnan left. We have a diagnosis of 140/90. That 140/90 for diagnosis of hypertension is based on office blood pressure. But if you're going to do a home blood pressure monitoring for the same 140/90, the target is going to be 135/85. Similarly, if you do a 24-hour BP monitoring, it is going to be 135/85 for daytime blood pressure. And if it is going to be 24-hour entire monitoring, it is going to be a 130/80. So you must remember, first thing, it's not that same target for everybody. So we have made a diagnosis and said 140/90 for everybody is fair enough. Now, when you start looking at which is going to be the better method to record the blood pressure of 140/90 in the clinic, it requires a lot of sub-conditions. Make the patient sit down for 5 minutes, back supported, feet flat on the ground, not talking, not smoking. All the sub-conditions, if you start doing it, you will never see more than about 10 patients per day. You can never see many patients. So if you are going to ideally check your blood pressure, encourage home blood pressure monitoring. When do you check? Once in the morning, once in the evening. There are a lot of specifications for that. Wake up, sit down for 5 minutes, first blood pressure, 1 minute later, second, 1 more minute later, third. Average of the second and the third is going to be the best. And again, in the evening, before the evening meal, is going to be 2 times a day blood pressure. What is ideal is ambulatory blood pressure, but not possible at all times. Why do we need ambulatory blood pressure is more important? It is going to be because of 2 main reasons. One is a sustained hypertension, but there are 2 other entities called the white coat hypertension and a masked uncontrolled hypertension. The masked uncontrolled hypertension is very interesting because nearly about 23% of patients have masked uncontrolled hypertension, and they have a normal blood pressure in the office, but a 24-hour blood pressure will be abnormal, or a home blood pressure will be abnormal. Similarly, white coat hypertension, where the office BP is normal and the clinic blood pressure is going to be, clinic blood pressure is high and the home BP or 24 hours normal. So looking at it, looks like when you diagnose hypertension, encourage the patient to start home blood pressure monitoring. If you're in doubt, go for an ambulatory BP. Anybody with difficult to control hypertension, use a 24-hour ambulatory blood pressure. If you think a young person with a tachycardia, ambulatory blood pressure will be a good choice. This will be the simplest guideline. When you look at patients who are getting treated, whenever you're aggressively going on drugs, I think you should always use an ambulatory blood pressure, because I've seen several surprises you keep noticing where patients are well under control but have a white coat hypertension, which is not restricted to normotensive patients or borderline hypertension. Even a patient who's under treatment can have a white coat hypertension. You don't stop the drugs, you don't do any abstinence, you check your blood pressure on drugs, on regular medication, and there is no question of stopping drugs and checking blood pressure. I think that should have answered all the questions that you've asked, sir.
Thank you so much, my dear friend, Dr. Prabhakaran, sir. Next question to Dr. S.P.S. Subramaniam, sir. He's a leading nephrologist and working with COVID patients. Also, I had treated more than 500 patients. Routinely, diabetes control is a very tough target in COVID patients. One important observation is hypertension. Hypertension is not at all there during the treatment of COVID-19 because there is a parasympathetic overactivity. We are observing many patients with sinus bradycardia, no hypertension during the first 10 days. After post-COVID period only, they are getting the hypertension. This is our observation. What is the common problem encountered in hypertensive patients with COVID? Over to Dr. S.P.S. Subramaniam.
Yeah, first of all, thank you very much, sir, for this opportunity. And what you said is absolutely right. This is a very common observation in our COVID patients. So many of our COVID patients, their antihypertensive drug requirement comes down, and many of them become transiently normotensive. So it cannot be called as remission of hypertension, but definitely we see a lot of patients' blood pressure becoming normal without antihypertensive drug. And as you already commented, it may be because of autonomic abnormalities. So some of the COVID patients, we observe tachycardia, some of the COVID patients resting tachycardia, some of them having bradycardia. And another important reason, maybe because I'm not sure, because we are not very keen about the fluid management inside the hospital. So how much fluids they are taking, how much salt they are taking, all those things we are not very sure. But it's quite right that in the post-COVID period, we have to be very judicious in administering antihypertensive drug. Ideally, as the previous speaker told, I think we'll have to do a home BP monitoring ideally, and accordingly, we have to titrate the antihypertensive drugs.
Thank you, Subramaniam.
Thank
Over
you,
to Dr. B. Mohan, sir. Over to Dr. Mohan, sir. Living to 100 in diabetics, it's a hype or reality in diabetic patient, because the average longevity for the Indian population is 66 years, USA 78 years, and UK 81 years, Japan 82, Hong Kong 82, Iceland 82. But Indians are routinely, my dear friend Dr. Sasam Joshi sir, usually he says, Indians are stress givers and stress taker. It is in the mitochondria of Indian population. We are well pandit in medical as well as engineering. Or compared to Indians are very popular in mathematics. So what is your opinion regarding this, whether it's living to 100 in diabetic patients really hype or reality, sir? Over to Professor Dr. B. Mohan, sir.
Thank you, Dr. Palniappan. I would also like to thank you and API for inviting me. It's a very distinguished panel, and I'm learning a lot. I've come here mainly to learn from my distinguished colleagues. Now, with regard to your question and your observation, you are actually right, because the average lifespan of an Indian male is about 67, 68 years now. And the average lifespan of an Indian female is about 69, almost up to 70 years. Remember, it was only 35 years at the time of independence. And so we've come a long way. We're almost come to 70 years now. It's also a fact that in general, type 2 diabetes shaves off about 6 to 7 years of life. And type 1 diabetes shaves off almost 15 to 20 years of life of an average diabetic patient. And therefore, with this background, one would not expect people with diabetes to live beyond 60 years. If that mathematics was correct, and if the average lifespan of a male was 67, 69, and 6 to 8 years you're going to lose, then you very rarely see diabetic patients above 60 years of age. Now, it is true that very often we lose people, and we have published 2 long-term follow-up studies, one from the CUP study and the other from the CURE study, where we have compared mortality of the diabetic and non-diabetic people. And there's no doubt that at younger age groups, the mortality rates are definitely higher due to cardiovascular disease, due to kidney disease, and due to other factors. But having said that, there are groups of survivors. And in 2013, in our diabetes care paper, we showed for the first time in the world, actually, 40, 50, and 60-year survival in those with type 2 diabetes. I'm not talking about children who get diabetes. I'm talking about adults who get type 2 diabetes. This is the first report in the world which showed 40, 50, and 60-year survival in type 2 diabetic patients. So that paper was the one which got me the Harold Rifkin Award of the ADA, because it's the first and the only paper in the world to have shown that survival. Subsequently, we published another paper. We took people who are crossed 90 years of age and who had diabetes. So you may say, maybe they got diabetes 1 year earlier. Maybe they got it 89 and so they've crossed 90. No, the criteria was they should have lived minimum 30 to 35 years with diabetes, and then they should have crossed 90 years. So we collected a series of 328 patients, of whom many had crossed 90, some had crossed 95, and a couple of them had crossed 100. Now I have at least 3 or 4 patients who have crossed 100 years of age. One of them had diabetes for 60 years duration. He got it when he was 40, lived for 60 years, crossed 100. Some of you may even know him, Professor Chitti Babu. S.V. Chitti Babu was a vice chancellor of 2 universities. He had diabetes for 60 years and got it when he was 40 and crossed 100 years. Now, how did these people live and what is different? Now, that's what we have been doing. We're doing genetic studies. We're looking at one thing is clear. The ABCD mantra, which we talk about, works very well. And all the A and the B and the C have already been talked about by earlier speakers. So what is ABCD? A is A1C should be less than 7%. B is the blood pressure, 140/90. And C is the LDL cholesterol, which should be normal cholesterol. So C. And D, of course, stands for discipline, which means regular walking, and which Dr. Narsingh very nicely summarized in his introduction talk. So those who had these ABCD were able to live long. Of course, they might have some additional genetic factors and so on. We're looking at various genes, longevity genes. We're studying other things. But one thing was clear. None of them had very high LDL levels, very high blood pressures, or uncontrolled diabetes. So simply by focusing on what we have to do, which is what this whole symposium is all about, the ABCD is what we're going to talk about again and again. We have now proof that people can live up to 100 years. If you ask me, will everybody live up to 100 years? Well, God, Upparwala there up decides whether we will live up to 100 years. Even if we have all our ABC under control, we can get COVID and die tomorrow. So that is a completely different issue. But all we can do is to do what we can do, and that is to look after our ABCD. So by doing that, I believe both our papers showed that it's only simply controlling the ABCD. And if you do that, simple thing we are supposed to do as physicians, we can help our patients to live, not only as somebody that Manjal said, it's not just the living long alone, we have good quality of life. They should not have complications. What's the point if he's blind and lost his leg and can't walk and he has a stroke and he lives up to 100? There's no use. So good quality of life, I believe it is possible. Thank you.
Sir, one rapid fire question to Dr. Mohan, sir. Usually diabetic patient with good control, usually they will live 10 years more than the people, those who are not having diabetes, but suppose they are having metabolic syndrome, other things. But if they are not under control, the longevity will be lesser than 10 years. Usually diabetic patient, if you control microvascular disease, all diabetic retinopathy, nephropathy, neuropathy can be prevented. But ADA says in the early phase, if you control adequately because of the legacy effect, macrovascular disease also can be postponed by controlling diabetes. What is your opinion regarding Indian statistics, sir?
I think the long-term studies have very clearly shown that both in patients with type 1 diabetes, as shown in the DCCT study, which was later followed up as the EDIC study, and then in the UKPDS study from UK in type 2 diabetic patients, that the first 10 years or first 5 to 10 years are very important. So, and that's been our experience as well in our long-term publication. So if you focus on the first 10 years and they're able to get their sugars really under good control and all the other parameters, not just sugar alone, you have to get all these parameters under control. If you get them all under very good control, then the next 10 to 20 years, they seem to be protected. Even after that, very unlikely after 10 years that they loosen up everything and then lose their control. Normally, the discipline continues for some more time. But even if they did, animal experiments have shown the first 6 months of the animal, you control well, and then you don't give them insulin. The other way, you don't control them for first 6 months, and then you control them. Very elegant animal studies have shown that it's the first period which is very, very important. So in human beings, it translates to about 10 years. The first 10 years, if they look after themselves, is very good. The problem is you can miss diabetes for 10 years. You may not even have symptoms. You will say, I don't have symptoms, I didn't go for checkup. You can miss many, many years. And that's the value of an annual checkup. Once you go for an annual checkup, you can detect it in the pre-diabetic stage and you can even reverse it at that stage. If you don't have anything, I had a teacher of mine who was a surgeon who came to me and I asked him, when did you get diabetes, sir? Last week, he said. I said, last week, sir? Are you sure? Because when I examined his feet, I couldn't feel, the pulses were a little bit reduced and the ankle jerk was gone, the knee jerk was gone. He was not able to feel the pinprick as the Epstein filament test was positive. So I said, this looks like a long time. When we sent him to the eye department, when they closed one eye, he was blind in one eye because his retinal bleed in one eye. He didn't know because the other eye was there. And then when the creatinine values came, it was already 3.2. So he had not gone for a checkup for 10, 15 years. And it's only when he had a small trophic ulcer or something, he went for a checkup and then found out his diabetes. He's lost 15 years. Now that you can't get back. He died within 2 years. You might know who I'm talking about. He died within 2 years, went in for dialysis, and then he died within 2 years' time. So this is a kind of tragedy which we should prevent. And so early diagnosis, early screening, detection, good control, I am sure can give a long and healthy life to our diabetic patients.
Thank you, Dr. Mohan, sir. Over to Dr. Kumaravel. He's an endocrinologist, my dear friend. Will you treat pre-diabetes and pre-hypertension really only with the lifestyle therapy or with the drugs? Many times the AAC guideline says with the symptom, without symptom, only one diagnosis, two diagnoses like that. And Dr. V. Mohan, sir, usually he's telling about pre-diabetes also. Really, will you treat to increase the longevity, to live longer, to 100 years? Will you treat pre-diabetes and pre-hypertension? Over to Dr. Kumaravel.
Thank you, Dr. Palniappan and API for this opportunity. And it's a real privilege to be among the expert panel. And I'm sure pre-diabetes, when you say pre-diabetes, it includes all three grades, like your fasting between 100 to 126, and your post-GTT between 140 to 200, and your HbA1c between 5.7 to 6.5. And there have been a very clear-cut guidelines when to treat pre-diabetes with medications. Of course, lifestyle modification is definitely required, and bringing blood sugars under control is definitely required. But when you treat with medications, we have every drug has been tried in pre-diabetes. We have data on acarbose, we have data on DP4 inhibitors, and now we do have studies on SGLT2 inhibitors also. But one drug which has been approved for treatment of pre-diabetes as per ADA guidelines is metformin, which can definitely be used in pre-diabetic patients, especially if they are obese and when you have other signs of insulin resistance. Because controlling blood sugar and maintaining euglycemia as early as possible will definitely have a legacy effect in the future, and it will definitely help us to live 100 years.
Thank you, Kumaravel. Again to Dr. Kumaravel, glycemic target in COVID patient in ICU, non-ICU, and OP.
Yeah, glycemic target, I think recently we had a paper which was published, which has looked at the glycemic targets and the adverse outcomes. So it had been very clear in that paper, which has suggested blood sugar in ICU and inpatients between 70 to 160 was the target where they had a very good outcome. Any blood sugar less than 70 or any blood sugar more than 160 had adverse outcome in terms of COVID outcomes. And as far as OP is concerned, I'm sure every fasting blood sugar should be less than 130 and your postprandial should be less than 180.
Thank you, Dr. Kumaravel. Over to Professor Dr. V. Mohan, sir. Among the SGLT2 inhibitor, which is superior, empagliflozin, canagliflozin, dapagliflozin, with the target organ damage, sir?
I think all the three of them are good. We have good CVOT data on all three of them. All three of them are very clear in one aspect, prevention of heart failure or reduction of the risk of heart failure. Uniformly, they are very good. As far as the kidney is concerned, more and more data coming that they have nephroprotective effect. They reduce the albuminuria. So that as far as weight reduction is concerned, they're all good. As far as A1C is concerned, they're all good. But if you look at the CVOT, published CVOT data, only EMPA had all the four. That is, they had the 3-point MACE and the CV death, and all the factors were satisfied only in the case of EMPA. In the other two, you had some of them heart failure. Of course, hospital heart failure came out in all of them, but CV death did not come out to be superior. They're not inferior, but they're not superior as far as the DAPA and the CANA was concerned. But then CANA had some benefits as far as the kidney is concerned. So I think overall, it really doesn't matter which one you use. They seem to have a class effect in many of them. And the trials also, they are based on inclusion-exclusion criteria. So the number of people are included in the trial, the type of population included in the trial, all that influences the result. So it's not fair to take one out and say, this drug is inferior, this drug is superior. All that we can say is that the SGLT2s have now become the miracle drug. In fact, since cardiologists are here, I can, in a lighter way, and say that they hijacked it from us. We started it, but then they hijacked it and they said it's our drug because they are now using it even in non-diabetic patients. And then the nephrologists hijacked it. They said, no, it's a kidney drug now. I'm sure soon the hepatologists may hijack it because there are trials going on in fatty liver. So maybe in fatty liver, if the trials come out, they'll start using it in fatty liver. So all said and done, it's good news. That means if a diabetic patient has any of these, heart, kidney, liver, weight, blood pressure, sugar, anything, it seems to be good. It seems almost too good to be true. So only hope that in the long term, we don't get some side effect. But so far, it's been great going. And all associations are bending backwards now to put these as almost as a first line drug or immediately after metformin whenever there's a high risk of ASCVD or risk of heart failure or kidney involvement. These drugs have come to play a role. So really, we are very happy that such a group of drugs have come.
Sir, can we use SGLT2 inhibitor in non-ICU patient, especially COVID patient, when the patient is compensated heart and no AKA or ALI? Can we use in non-ICU COVID patients, sir?
I think in a non-ICU setting, you can continue any of the oral anti-diabetic drugs, including the SGLT2s. In fact, dapagliflozin was tried in the ICU setting itself, hoping that they'll have some benefit, but the trial turned out to be neutral. It is neither beneficial nor it's bad. So even in an ICU setting, I would argue that there is no contract in, but I would hesitate to use it when there is fluid overload of a fluid imbalance, electrolyte imbalance. In that kind of a setting, insulin is definitely, because you're going to give steroids anyway, and when steroids are given, insulin has to be given. So accept that, and you clearly said non-ICU. In that kind of a setting, I think it's ideal to use drugs like SGLT2s, and if the blood sugar control is quite good, patient is at home quarantine, or not in ICU in a hospital, they can continue whatever drugs they are on, unless the sugars are very high and unless you're going to start steroids. If you're going to start steroids, the whole equation changes. Then insulin almost definitely has to be given. Otherwise, there's no specific contraindication to any of these drugs, whether it's metformin or sulfonylurea, or I wouldn't give pioglitazone, because you'll definitely increase fluid overload and risk of heart failure. Except that, I don't think, and for liraglutide, there's been some 1 or 2 papers, although not definite, saying that perhaps you can avoid in that situation. But other than that, I think any of the anti-diabetic drugs can be used.
Sir, what's your opinion, Dr. Kumaravel? Kumaravel?
Yes, Palniappan.
Yeah, regarding SGLT, sir says, what's your opinion? Same opinion?
I totally agree with Professor Mohan, sir. Definitely, it can be used as long as patients are not on steroids and they are in compensated state. It can definitely be used.
Yeah, thank you, Kumaravel. Over to Professor Dr. Rajesh Upadhyay, sir. Sir, game changes in gastroenterology for living to 100 in old patients, sir. Sir, please unmute, sir.
Thank you very much. To be honest, I don't think there has been a huge game changers, although in the terms of treatment, there has been a huge amount of work done in the era of gastroenterology. We started off with liver transplants, which are preventing deaths, and the success of liver transplant is well known all over the world. There is this huge hype about the H. pylori or the Helicobacter pylori, which can cure ulcer disease. But I think the most important thing is, and you're talking about hold. When you're talking about hold, you cannot hold the hold unless you do a few things. That the first is prevention. So we must think of the prevention right from the word go. The second is health promotion. And that also includes, I think, in my opinion, you see, awareness about diseases in the general public, because we are not only saying how I can reach 100, but how my patients can reach 100. And if they are not aware of diseases and they are not aware when to go for checkup, and the government does not have a very effective screening programs, I think all will go to waste. And third is clearly what you have been talking about is about the treatment, not only effective treatment, but very appropriate treatment. So appropriate and effective treatment. So when it comes to the game changers in gastroenterology, I think what we are going to see, and I'm a great believer in the old Indian wisdom of Ayurveda. Whether you're talking about lipids or whether you're talking about hypertension, diabetes, The Indian wisdom said that all diseases arise from the abdomen. And if you look at the data which is emerging gradually, particularly about the gut microbiota, and that is an amazing amount of work is being done. And I think that is going to be a game changer, because that has a huge role to play in health and disease. Imagine, Dr. Palniappan, here if you take gut microbiota as an organ, we have got about 10 to 100 trillion organisms inside our body, particularly in the gut. And the human genome consists of about 23,000 genes, whereas the microbiota has about 3 million genes. So you can imagine why is so much of, and the third thing I would say is, the largest organ in your body, which is supposed to be, well, let's forget about the skin for the time being. Liver is the largest organ, second to skin. And the largest organ weighs about 1.5 kilograms. Whereas if you put the entire microbiota together, you know what is the weight? About 2 to 2.5 kilograms of the weight of our body is going to be because of the microbiota. So everything in life has a purpose, and microbiota therefore must have a purpose if we consider it as an organ in itself. And the purpose is clearly, it is very important for health and for disease. And it has got such amazing actions which you just cannot even imagine. And the best example which I quote is, let us look at the largest animal, or one of the largest animal, the elephant. And what does the elephant eat? It thrives on leaves. But you see, this animal has got huge muscles also. So where are they deriving their proteins from? And it is clearly that they have got a different set of microbiota inside them, which is able to convert their leafy diet into a protein as well. So the functions of the bacteria inside the body is huge. It has huge metabolic functions, energy functions, prevention, immunity functions, prevention of diseases. And if you disturb it with antibiotics, with bad lifestyle, and with other factors, then it clearly can cause disease. So I think we have a huge amount of data which is coming up. And one of the very interesting data I can tell you, which really shows how important the gut microbiota are, that if the fecal microbiota from an obese human or an obese mice is given into a germ-free mice or even ordinary mice, and you give them a standard diet, they will actually become fat. So you have changing the phenotype just by changing the gut organisms. So I think they have an immense potential in treatment of diseases, in prevention of diseases, which we have not yet conquered. But I think the fecal microbiota transplant, you can see the role of that in a number of diseases which is emerging now.
Sir, please unmute, sir. Sir.
So I think if we are to live till 100, Dr. Palniappan, I think we have to look at all the places on this earth where people are living to 100 in the maximum. And that brings us to the question of the blue zone. We must follow what they are doing, what they eat, how they exercise, what community living they are doing, what spiritual level they have achieved. And I think you will get all the answers from the nature itself. So I am a great believer in nature now. Certainly we need to have very effective, appropriate treatment for diseases. But as far as gastroenterology is concerned, you will find in course of time that it is the manipulation of the gut bacteria which will become the key to solving many of the problems and increasing our life to 100.
Sir, one important question, Rajesh Upadhyay, sir. So routinely in a diet, that is dermatologists also, psoriasis, all gastroenterology patients, we are routinely, many patients, they are putting on prebiotic and probiotic Bifilac, and naturally increasing the gut microbiota, stress, reduce the stresses, natural food and vegetarian food, all those things. Will you advise hold the patient routinely for a prebiotic and probiotic, sir, to improve the longevity?
From the evidence we have till now, the answer is no, not for all patients. But we have very clear evidence about prevention of diarrhea and treatment of diarrhea, prevention of Clostridium difficile, colitis, and prevention of other diseases, even, for example, respiratory infection, cancers, etc. But the problem is when we say probiotics, what exactly do you mean? Which bacteria? Which cocktail? And we need to work out what should be the dose, what should be the best cocktail or the best quantity of individual bacteria for individual diseases. As of now, we have got a sort of, more of marketing, and you've got hundreds of probiotics floating around. Everybody uses it for their choice, but we do not have clear guidelines as of now. So I think we should put it in a patient, but specific indications. As far as the COVID era is concerned, COVID infection causes dysbiosis in a huge manner. And in addition, the use of antibiotics and various other drugs in patients with COVID leads to huge amount of gut microbiosis. And in the post-COVID situation, we are seeing patients coming with intestinal dysmotility and gas in a big way. And that is one area where we are using probiotics in sufficient amounts and getting results as well.
Dr. V. Mohan sir has done a lot of research work on especially anti-diabetic drug, that is AGIs, to improve the gut microbiota, especially that is agarbose. Sir, what is your opinion, Professor Mohan sir?
Our trials on acarbose, actually, I don't know how you knew about it, but we've just started these trials, and we don't have that. We have done work on gut microbiota, and is very happy to hear Dr. Upadhyay talk about it. We've just published 2 papers back to back in Genome Medicine in collaboration with the Danish group, where we have described the gut microbiota in normals, pre-diabetics, and diabetics in India and in Denmark. There are vast differences between Indian. Actually, I used to joke by saying that if you give me a bit of poo, looking at the poo, and the gut microbiota can tell you whether Indian or Danish, although probably there are better ways of doing it, but it's so distinct. They're completely different. The Danish gut microbiota is so different. There's no overlap even. It's so very different. We're a little disappointed that the pre-diabetic and the diabetic and the normals did not come out so easily. We thought it would come out, but that didn't come out so easily. But having said that, now there are drugs which can improve the gut microbiota, and one of them is the AGI. We also reported in the same paper the effects of metformin on the gut microbiota, but the AGI ones, acarbose particularly, we are working on this, and we just started our trials. But there are trials from China which have shown very good studies, which have shown that if you give acarbose, it actually improves the gut microbiota. So there is something in the anti-diabetic drugs, and particularly drugs like acarbose. One of the things which I find is that I didn't realize it myself, is that after the age of 60, 65, your gut microbiota seems to change. And I think a lot of the constipation that we are seeing in elderly people is due to this. And use of probiotics, simple. Earlier I used to prescribe cremafin, this, that, all kinds of drugs. Now we just give them probiotics and it's done. Their constipation goes away. So I am a firm believer that although a lot more work needs to be done, and Dr. Upadhyay is absolutely right, it's an emerging field. But I believe that in the elderly, giving them probiotics is definitely good. Of course, with the antibiotic, with that, there's so many other indications you can give. But in the elderly, definitely, I think they need a probiotic supplement. Do you agree, Dr. Upadhyay?
I think I would absolutely agree, because in the elderly, the threshold for giving is certainly lower, and the beneficial effects are probably more as well.
Yeah.
And sometimes it may have, what I have never realized, it may have a placebo effect as well.
Yeah.
But whatever effect,
yeah,
but they are benefiting, and it is the benefit which we are looking for. As you rightly said, if somebody with constipation can be treated with probiotics, why should we use other drugs, particularly the stimulants?
Correct.
Certainly should not be used.
Thank you.
Sir, thank you so much, sir. Over to Dr. Rajesh Upadhyay, sir, and psychiatrist Dr. Sendil Velan, sir. To increase living to 100 with the diabetes, that is hold, can we take red wines 2 to 3 cups a day, which increase the longevity to live 100? Psychiatrists usually say, I won't advise alcohol because Indian population, they will not, they will not take one or 2 drinks per week. For Indian hold patient, will you advise to live 100 and social drink, all those things? There are 2 controversy. Answer will be there from Rajesh Upadhyay, sir, as well as Sendil Velan, psychiatrist. Sir, what is your opinion, sir? Go to Rajesh Upadhyay, after that Sendil Velan.
Okay. Well, being a gastroenterologist and a liver person, we are all against alcohol. And certainly in a patient who's got a disease, particularly diabetes, lipids, obesity, or hypertension, I think alcohol is a no. So let's be very clear. However, if you look at, and I'm coming back to the blue zone effects, there are areas, particularly the Icaria in Greece people, or Sardinia in Italy. They are the ones who've been taking small amounts of red wine. And there have been a number of studies on that. And in fact, in 2019, there was a paper published in the Gastroenterology, which clearly showed that a moderate amount of red wine, which means up to 2 glasses, but when I say glasses, I do not mean that 2 full Indian glasses, particularly the Patiala glasses. What I mean is 120 ml of wine is considered to be 1 glass, or what we call is 1 unit, which is same as, let's say, 30 ml of whiskey or 350 ml of beer. So 120 ml and is considered 1 glass, and the studies which were done were in people where they were taking about 2. And what it clearly showed that there was a improvement in the gut microbiota in terms of composition, in terms of diversity. There was evidence of efficacy in reduction of obesity, in improving the lipid profile, and therefore it had an overall beneficial effect on health. And therefore, if we go back to a healthy population, I consider probably the Indians are a little more callous. So if you say you have 2 glasses of wine, they will really fill up their glasses and have 2 huge glasses of wine, which is going to be counterproductive. In fact, 2 glasses of wine have been shown to have cardiac benefits, have been shown to have beneficial effects on constipation, in relaxation, better sleep, better. So I think there are lots of areas and lots of evidence to suggest that if we really stick, and that I'm emphasizing, if we really stick to 2 glasses of wine, it may not be a bad idea for the healthy population who want to live longer and enjoy life. However, once you talk about should it be given to diabetics, I would say not to the Indian diabetics for certain. In fact, even for fatty liver disease in the West, they say 1 to 2 drinks may be allowed. But we in India say, oh no, a big no, because we are more callous. We are, as you said, we create stress amongst ourselves. We create stress amongst others. And when we sit down to relax, we take everything more than what is required. So certainly not for Indians.
Can I just add a brief comment, Dr. Palniappan?
Yes, sir.
So about alcohol, there is Indian data is not very strong, but the data which we published with Dr. Durraj Prabhakaran from All India Institute, the industrial cohort study which we published, we found that there was no, normally we talk about a U-shaped curve or a J-shaped curve and so on. We couldn't find that. We only found in fact, we didn't find any benefit. So people who didn't drink at all seem to do well. And as you go up, the alcohol only did worse in terms of mortality, in terms of cardiovascular risk, in terms of, so maybe Indians are wired a little differently. So what I would say is French wine is good for French people because they have a Mediterranean diet. Their diet is completely different. We have so much of carbohydrate, triglyceride is going so high, our LDL is also not so good, and we have a small dense LDL, and we have low HDL, and we have everything which Dr. Narsingan and all described. On top of that, when you add wine also or alcohol, I'm not sure. And so we really don't, the data comes from the West and we really don't have the data. Of course, in the blue zone, they do talk about having a glass or so of wine every day, but our data doesn't support it so far. I may be wrong, but this has been our data.
No, I would entirely agree with this because the Indian population we are treating different set of people and we have to take the local factors into consideration.
Sir, Dr. Senthil Velan, he is treating a lot of de-addiction patients, alcohol de-addiction patients. Nowadays, I am talking about the red wine alone, especially when the patient is not having the family history of alcohol dependence. Will you advise red wine 2 to 3 cups a day? Because many de-addiction patients, they will start with small alcohol, slowly they will increase, they will become an alcohol dependence. What is your experience? Will you please advise red wine 2 to 3 cups a day for whole patient to increase the longevity? What Western data is saying? Over to Senthil Velan.
Oh. Thanks for this opportunity, Dr. Pranayama and API. So I am running a de-addiction center. So as a psychiatrist, I would not advise to have alcohol, even if it is a social drinking, because there is a lot of chances for you to become an addict over a period of time. We said that alcoholism is a growing disease. So most of the time, it's the gene and the environment that decides whether you are going to maintain as a social drinker or you become an addict. So once you develop a tolerance, this is the first sign of you becoming an addict. So tolerance means if you are taking small amount of alcohol and you are getting that kick in the initial stages, the same kick or the same high or the same euphoria, you don't develop over a period of time. So to have that euphoria, you gradually tend to increase the amount of alcohol. Even if it is a red wine, you tend to increase the amount. I have seen patients, and I admitted some of the Christian priests who only drinks red wines, but their amount will be 3 to 4 bottles per day. So they initially start 1 or 2 drinks per day, and gradually, if their gene is having that addiction potential, or their environment, or if they are having a mental illness, or if their work is very stressful, there is a lot of chances for them to become addicts over a period of time. So if you are able to maintain strictly as a social drinker, I would advise you have 2 drinks per week, but not every day. And I would like to tell a joke at this moment. And you all might have heard about Kushwant Singh. Is a great writer. He died at the age of 99. And he once told a joke that you already heard about B.K.S. Iyengar. Is Bellur Krishnamachari Sundaraj Iyengar is a great yoga guru of this country. He lived up to 96 years of age. He practiced yoga till his death. And Kushwant Singh had his whiskey till his death. So he once commented in a lighter sense that whiskey has an edge of 3 years over yoga. So as a psychiatrist, I would advise not to have more than 2 drinks per week, and you should maintain as a social drinker. And if your father, grandfather, siblings are alcohol addicts or any substance addicts, better not to touch it. Thank you.
Sir, if you allow me a minute on this.
Yeah. Tell me.
When we talk of red wine, we basically are looking at the resveratrol in it. So when we talk of resveratrol, why don't we think of the foods which are rich in resveratrol? And as Dr. Mohan sir already had a study on cashew nuts, which are a super source of resveratrol, but keeping in mind the calories from cashew nuts. Apart from that, we have the pistachios. We also have the red grapes with the skin. which are a source of resveratrol. So why do we only have to look at red wine for the source, which in turn provides, if we say 1 serving of red wine, in other words, if you want to equate it to 2 drinks of whiskey, you say usually 5 ounces of red wine, which means 130 calories, 10 grams of alcohol. And I think Dr. Upadhyay will agree with me that 10 grams of alcohol over a long term will in turn lead to, fatty liver disease, cirrhosis, and then the story just goes on. Not only that, as Dr. Mohan sir said, very clearly said that we are basically carbarians in India. And with the carbarian, background, we have a raise in the TGL, and in turn, all this cascades several NCDs, whether it is HOLD, whatever you call it. So I think it's better to be away from it in the Indian setup than, vouch for it.
Yeah, regarding to Dr. Sendilvelan, Professor Sendilvelan, yoga is one of the treatment. It's one of the important practice in India to increase the longevity, to live longer, to 100 in old patient. Yoga is actually, there is a balance between sympathetic and parasympathetic imbalance will be there. So over sympathetic activity, to reduce the sympathetic activity or increase the parasympathetic activity, yoga is a well-known factor, will reduce the stress and strain, all those things. Really, whether the yoga is really helping the patient to live 100, what is your opinion regarding yoga to live longer to 100 in old patient? Sendilvelan.
Yes. So I personally feel that yoga is a much hyped exercise in this country. Yoga is really good, but you should consider it as an exercise, like you are walking, you are jogging, you are swimming, but it's not going to treat many of the mental illnesses or the physical illnesses. It helps somewhat, but who are living up to 100 years by doing yoga are only the yoga gurus. So yoga gurus, they live yoga, but you people don't live yoga. So if you live yoga, definitely you will reach 100 years if your gene helps also. But in most of the time, what happens, doing yoga regularly will not be interesting to most of us. So even if I prescribe yoga or meditation for many of my patients, they don't try it even, or they don't continue it after 10 or 15 days, because it needs a lot of patience, it needs lots of hard work, and it needs a lot of interest into it. So by doing yoga alone, most of the patients, they will get bored after some 1 month or 2 months or maximum of 1 year. And what happens in yoga is, I just want to demystify the things, decoding that yoga. So yoga and meditation, there are two different things. So every religion has got yoga-like things. So in our Hinduism, you call it as yoga. In Taoism, it's called transcendental meditation, and in Buddhism, it's called Zen. So all are almost the same. So what we are doing in yoga is we are concentrating and we are controlling our emotions and our thoughts by using some mental devices. Let it be sound like Om or One or something like that, and you'll be concentrating on your breathing, and you will control your emotions as well as your thoughts, and you will be passive at the time. What happens during this activity is that your sympathetic overtone will be definitely reduced, so that your parasympathetic activity will go up definitely over a period of time. If you do yoga regularly, as I already told you, if you live yoga, definitely your sympathetic overactivity will come down and your parasympathetic activity will go up and you will become stress-free. But doctors like us, because we are working for 17 to 20 hours per day, I think. So it's very hard for us to have time to spend on yoga and meditation. So for us, it will be better to go for relaxation exercises. So these are all the things which are decoded from the yoga, and the very chunk of the health point from the yoga is taken by this relaxation exercises. So some of the relaxation exercises are Jacobson's progressive muscular relaxation exercises. What we are doing in this is we are simply relaxing our whole body muscles from toe to head, and we are taking deep breaths frequently, and it will last for just 15 to 20 minutes. Definitely you have up to 75% of the benefits from the yoga that you are going to do for more than an hour.
Thank you, Dr. Sendilvelan. Another important question is, have more sex, if possible, will increase the patient to live 100. Many patients in psychiatric patient, whether under sex or over sex, will lead on to psychiatric problem. Generally, they will tell psychiatrists, most of the psychiatrists. If you have more sex, if possible, will increase the longevity to 100. What is your opinion, Dr. Sendilvelan, sir? And over to Dr. Rajesh Upadhyay, sir, also.
Okay. So regarding sex, it's like an appetite. So you cannot eat more than 10 idlis or 15 idlis for a health point of view. If you are really interested in taking idlis 5 or 10 or 20, definitely it won't harm your body. But if you are taking it as a treatment, taking 20 idlis or 30 idlis per day, definitely it will harm your body. If you are basically having much interest towards sex, definitely it will help to improve your health. Definitely it will improve your health as well as your longevity, because most of the creatures in this world live longer when they produce their generations. This is a basic concept of creatures exploding. So sex is an important thing, but I don't know the complications of having that sympathetic and parasympathetic overactivity during sex, which can complicate with your because sometimes it may go up, the BP may go up to 200 by 130 or 140. I don't know how it complicates your patient suffering from cold, but definitely sex is a pleasurable activity as well as it's a relaxing, even if you are interested, but you cannot take that as a treatment protocol to improve your life.
Can I come in?
O2, Rajesh Upadhyay, sir.
Yeah. I think I entirely agree with whatever you said, but I don't think, Palniappan, you are talking about sex as a treatment modality. I think you are talking about sex as whether having sex can increase your longevity. Well, data on this is very scarce. I'll try to look it up also. But what I can say for certain, that anything which brings happiness to you, that happiness itself contributes towards longevity. So if you have a happy life with whatever you are doing, be it gardening, be it running, be it doing your gym, that happiness always helps in increasing your longevity. So I'm not looking at sex in a very scientific manner. I'm saying this is if somebody is enjoying it, and then certainly it will help probably in his longevity. Now, if you look at it is very interesting. I'm again coming back to the blue zone. The blue zone are areas obviously where the longevity is the highest, and there are some rudimentary type of studies from Icaria in Greece, and it was found that people who were between 60 and 100 they were having more sex than their counterparts elsewhere. So I don't know whether it is the outcome of the happiness which they already have that they have more sex, or whether sex contributes to their happiness and increasing their lifespan. But let us not try to bring in sex as a very scientific form of treatment. It is just a recreation. It's just a way of intimacy also, and bringing love and happiness to individuals, to a couple. And if that is so, I'm sure it is helping in increasing your lifespan. But let us not bring as a treatment. And I would also like to say one word about yoga, if I'm allowed. Again, yoga I consider as a health promotional activity, not as a treatment. And I will tell you, pranayama, which involves all the breathing exercises, has been used very commonly during the COVID times, particularly in post-COVID. And because it was a form of exercise, it is a form of breathing exercise also. So I see no harm in that. In fact, it is something, if you can spend 15, 20, 30 minutes and with which cools your mind, which relaxes you, and which gives you better oxygenation because you practice pranayama, I'm sure it is going to be helpful. So again, let us not look at yoga as a therapy, but let us look at yoga as a health promotional activity.
I just wanted to add about the pranayama part because Sendil will talk more about the yoga postures. So I was also about to say that in these COVID times, I think we should all do pranayama because number one, it will relax you. There is no doubt at all. You just do it. If you don't believe me, just do it tomorrow. Just sit down, take deep breaths, and immediately the tension that you feel in your neck, this is where you get stressed, will immediately go. It just takes 10 minutes, 5 minutes, and you'll find it's gone. Second, you're also improving your lung function, and you can't argue against that in COVID time when you should have better lung function. So from pranayama, absolutely no doubt. Yoga as a form of exercise, it's good. I cannot completely replace cardiovascular fitness. So I would say walking you do every day, and then you add a little bit of stretches. Yoga is very good for your bones and joints and muscles. There's no doubt about it. It also helps to improve your flexibility and so on. That's very good. But of these, I think the pranayama and meditation is the most important, because that is the one which is really going to relax you. And all doctors must find time for this. I would say 15 minutes, I think, of your life, if you spend for that. If I don't do it, and if I went into my office, I'll be throwing things and all. I'm such a hyper person. But the moment I do this and go, I'm totally relaxed. And that's been my personal experience.
Dr. Mohan, I'll tell you, we are treating a lot of fatty liver patients where we have to spend a lot of time telling them about diet and exercise. And what I tell them is, exercise is a combination of aerobic, isometric, isotonic, all exercises. Now, certainly the recommendation worldwide is 150 minutes per week, which means about 30 minutes per day. And the Americans or the Europeans will say 5 days a week. Indians will either be 7 days or none. So 30 minutes of brisk walking or cycling or even resistance exercises have been, because in Delhi, where I live, if you tell them about walking, half of the females tell me that they've got back problem or knee problem. Then I think you can sit down and do some resistance exercises. But add the 15, 20, 30 minutes of yoga and pranayama as well. So I use a combination. I think this combination of aerobic, isometric, and isotonic exercises is probably the best form of exercise. We need everything. And in fact, if you look at the blue zones, nobody does very heavy exercises, but they're doing small exercises. And in fact, my wife is a great fan of, doing little things at home, which, increases your bending or walking or little things at home. I think it's a wonderful thing.
Thank you, sir. Thank you very much, sir. Sir, may I go to Mrs. Meenakshi? Really, vegetarian food is good and non-vegetarian is food, which is better to live longer to 100. Especially non-vegetarian are changing into vegetarian diet, and vegetarians are changing into non-vegetarian diet. And I need the answer from Meenakshi Bajaj as well as nephrologist Dr. SPS Subramaniam. Because a nephrologist, Subramaniam, usually he says, in case of old patient, in diabetic patients, especially CKD patient, their lack of protein, high protein diet is only present more in the non-vegetarian diet. Will you advise vegetarian diet or non-vegetarian diet to live to 100? Over to Meenakshi Bajaj and SPS Subramaniam.
Thank you, sir, for the opportunity to be part of this panel. When we talk of vegetarian, non-vegetarian diet, I think we had an excellent discussion on gut microbiota. And one important message across here is, when you choose to be a meat eater or a lot of non-vegetarian food, there is an increase in TMAO. So that's one important thing which we need to keep in mind. And second thing, whenever there is gut dysbiosis, obviously it's the mother of all non-communicable diseases. And the blue zone very, very, very clearly tells us to retreat from meat. They have the pointers which say that in a weekly, you should keep away from meat. First thing is that. And in a month, how often can you take red meat? That is maximum 3 to 5 ounces through the entire month. And when it comes to egg yolks, choose only thrice a week. Obviously, if the cholesterol is going to be on the higher side and you're going to say Even then you take egg yolks thrice a week, I wouldn't agree, because 282 milligrams will come only from animal-based diet. You won't get cholesterol directly from any plant-based diet. Only the cholesterol will help to improve, when you are going to be on a plant-based diet. And third important thing when we talk of plant-based and non-vegetarian food is, the blue zone very, very clearly tells us that the Okinwa diet, which has mainly the anti-inflammatory properties, which was mostly in Japan, they found that they were consuming a lot of sweet potatoes, mushrooms, and spices like turmeric and fennel. And when it came to the Adventists in California, they found that they lived there 10 years longer than the other Americans, and they had followed a Biblian diet. That is whatever was prescribed in the Bible, which very clearly told them to choose mainly on legumes, seeds, green plants, mainly green leafy vegetables and others. And though the Greek island where the Mediterranean diet is followed, where a lot of fish is followed, I agree with that. But mainly you see that the pesco-vegetarian diet does much better than a vegetarian diet, but keeping in mind the dioxins in the fish and the mercury in the fish. So we need to go in for the river water fish, lake water fish, or the freshwater fish, and keep it minimum of 3 ounces 3 times a week. And apart from that, if you see that in Italy, where the blue zone is mainly concentrated in the 5 areas, one is in Japan, then in Italy, Greece, in California, as well as the Costa Rica island, wherein they found in Italy that mainly they followed a bread which was a whole wheat bread. And also the cheese which was prepared was the cows which were fed on plant-based diets, which was also rich in omega-3 fatty acids. One always talks of omega-3 fatty acids from fish, but one forgets that the fenugreek seeds, the whole grams which you and me consume, that is the rajma, chana, rongi, and the green leafy vegetables, the basic greens also are super source of omega-3 fatty acids, apart from the flax seeds. Then we also have, yes, sir.
Yeah, thank you very much, Meenakshi. As we are running short of time, the question will be 10 seconds and answer will be 30 seconds. If all the panelists are strict, we'll finish it quickly. Over to Dr. Meenakshi Sundaram. He is a famous neurologist, interventional neurologist. What is the hypertension management in stroke? Over to Dr. Meenakshi Sundaram.
Thank you, Dr. Palniappan sir, for bringing me in this very light audience, and I'm thrilled to see several of those inspiring people there. First, thank you, sir. So regarding stroke, there are many aspects of this. The first thing is that if you have an acute stroke and you have to thrombolyze, you have to reduce the blood pressure very quickly. The target is less than 185 or 110 before you institute thrombolysis. And then you have to post thrombolysis maintain around 180 by 105. This is for acute stroke. Within the first 24 to 48 hours of stroke, we do not reduce the blood pressure very fast. The reason is because we want a permissive hypertension for us to have a good circulation to the ischemic penumbra. Beyond 48 hours, then is when we try to achieve some homeostasis, and then we try to get the blood pressure to as normal as possible. We follow the same guidelines that was discussed in the forum previously. This is regards to the ischemic stroke. And when to give this antihypertensives, the timing also depends on the volume of stroke, the amount of hypoperfusion we face, and several other parameters we take. For instance, TIA, straight away we go for full treatment because the ischemic volume is less. On the other hand, if you have a large volume of infarction, you are more cautious. If you have an intracranial stenosis, then our parameters would change. That is with ischemic stroke. Hemorrhagic stroke, now the guidelines say bring down the blood pressure as quickly as possible. I'll stop here and I will elaborate on this if there are further questions. Thank you, sir.
Yeah, how will you prevent CVA, especially in old patient, to improve the longevity to 100?
So the same things that were discussed ultimately elaborately by people who will hold true with us as well. Of course, there are two controversies there. Only that I will try to highlight here. That is regarding the hypertension, there are no questions. We have to get down the blood pressure. Regarding the dyslipidemia part, we are actually not clear because we know that a very high level of cholesterol is a risk factor for an ischemic stroke. A very low level of cholesterol, that is de novo cholesterol, not the statin cholesterol. De novo cholesterol is a risk factor for hemorrhagic stroke. Both these things are very well known to us, but what we do not know is that what happens to those intermediate segment of people who have a moderate amount of cholesterol like you and me, whether this cholesterol is actually contributing towards the stroke risk, and number two, was there any benefit in reducing them? That point is not clearly known to us. The reason why I say this is because if you look at the management of stroke with anti-dyslipidemic agent, statin, you can roughly divide them into two zones, like the other zones they were talking about. One is a pre-statin zone. If you look at that, all the measures that were taken to reduce the cholesterol, they reduced the cholesterol but did nothing to treat stroke. Whereas only statins, they not only reduce cholesterol, but they also improve the stroke management. In other words, the improvement in statin treated patients is independent of the cholesterol level. The lowering of cholesterol is a byproduct that was not primarily intentional. So we have much to learn when it comes to statin. Therefore, I would say the role of statin is that straight away go ahead with statin if that is the case, but do not expect that cholesterol is what is responsible for this. That's point number one regarding cholesterol. Secondly, as it was pointed out by Mohan sir and many others, it should be remembered that when you look at the diabetes and stroke, again, the things are not very clear for us because the macrovascular complications when it comes to stroke, it has not really been shown to have significant benefit and association with diabetes as per the Western data. Sir may have different data, but the microvascular really helps. So these are two parameters which then, but reason for us to understand is that we will go by what is logical to achieve as much as euglycemia as possible. Other risk factors are all well known to us as well. Because here, one risk factor extra I always point out is if a patient is obese and has risk of obstructive sleep apnea syndrome, that may be considered an additional risk. And today, obviously, a glaring risk factor is COVID, which is a big coagulability and a big difficulty for us in treating patients.
What is the BP target in neurology, Meenakshundram?
Sir, in the primary prevention, it's the same target as what was discussed here, sir. When it comes to secondary prevention, as I mentioned, once the time limits are crossed, I mentioned about the acute window, thrombolytic window, up to 48 hours and beyond 48 hours. Those windows I have already covered. Also for the hemorrhagic stroke, I told you, now the guidelines say that if the patient has got a blood pressure of 140/90 during an acute hemorrhagic stroke, it is good enough. Only thing is, too lowering of blood pressure we don't like because that may produce adverse renal events in the same patients. That is how we target blood pressure in these patients. That's for our neurology as well. We have certain guidelines of different nature when it comes to subarachnoid hemorrhage. We follow certain other pathways because we also have to look at having a good perfusion to the ischemic areas, and we always look at the surrogate markers like consciousness, or we put an ICP and try to monitor. So those are different parameters here. Targets for primary prevention as well as for minor strokes, transient ischemic attacks would be the same as achieving normotensives or whatever was discussed here.
Sir, over to Dr. S.N. Narasimhan, sir. Isolated systolic hypertension, diastolic hypertension, or both hypertension, which is most dangerous, sir?
Isolated systolic hypertension is a terminology that needs to be used when the systolic blood pressure goes beyond 140 and still the diastolic blood pressure is less than 90. Then you consider that as isolated systolic hypertension, which previously thought it was only occurring in older people, but now we have realized that it also is an important cause of hypertension in younger people, even in adolescents also. Isolated systolic hypertension has been recognized. Isolated diastolic hypertension is such a rare problem. Probably it is correlated only with the underlying kidney disease and may not be really having a lot of significance. When you have both systolic and diastolic blood pressure going up, that commonly we see it in our clinical practice. Isolated systolic hypertension commonly is encountered in elderly people. The drug of choice would be calcium channel blocker followed by diuretic.
Thank you, sir. Over to Dr. S.P.S. Subramaniam. AC inhibitor and ARB usage during COVID pandemic, benefits and risk.
Yes, sir. There is a concern that AC inhibitors and ARBs may aggravate the severity of COVID. That is because when we use RAS inhibitors, they increase the ACE2 enzyme. And the ACE2, it acts as a receptor for COVID and may facilitate the entry of COVID virus. So that is the hypothetical concern. But in clinical trials, so we have had two randomized clinical trials. One is the Brace Corona, the other one is the Replace COVID trial, where they found that there was no difference in terms of disease severity in those who continued taking RAS inhibitors, and in those who stopped taking inhibitors, there is no difference in the severity of disease. This with respect to requiring mechanical ventilation, with respect to kidney injury requiring renal replacement, And a patient is already on ACE inhibitor ARB, and if he develops a COVID, we are justified in continuing ACE inhibitor ARB. But only caveat here is, if the patient develops hypotension, acute kidney injury, or hyperkalemia, definitely we'll have to stop ACE inhibitor ARB, sir.
Yeah. What is your experience regarding the AKI incidents during COVID patients in ICU? And what is the management? So many patients, in my clinical cases, I have treated more than 500 patients, AKI incidence is more than 50%. Shall we start them on low dose, that is a diuretic infusion, continuous diuretic infusion during when the patient is critically ill for the first 3 days? That is a torsemide, 5 ampule in 100 ml of normal saline, 5 to 10 microdrops continuous infusion will prevent the AKA with a promptly observation of the dyslipidemia and correcting.
Okay. So as you already said, the incidence of AKA is very high in the COVID population. So in one of the articles, major studies that was reported by the Kidney International, they found that the incidence of AKA is to the tune of 30 to 40%, which is quite high. And about 14 to 20% of those who develop AKA would require some form of renal replacement therapy. And the most common histology in patients who develop acute kidney injury is only acute tubular necrosis. So once the patient comes out of COVID infection, once he's discharged, so the chances of renal recovery are very good. So many of our patients recover normal renal function or at least come out of dialysis. And the major risk factors for requiring renal replacement therapy in acute kidney injury in the setting of COVID include severe COVID, like those who require mechanical ventilation, those patients who require vasopressors, and those patients already who have chronic kidney disease. So they are the major risk factors for patients requiring renal replacement therapy. And with respect to your question regarding diuretics, yeah, the hypothesis is that diuretics may reduce the energy requirement by blocking the sodium potassium 2-chloride transporter, but in clinical trials, it has not transformed as a nephroprotective measure, standalone nephroprotective measure. So nephroprotection, we have a AK prevention bundle that has been proposed by the KDIGO, so which includes fluid resuscitation. Fluid management is very, very important. We have to optimize the hemodynamics. We have to avoid nephrotoxic drugs. So all those bundled care approach is more important than simply sticking onto one approach like diuretics. Thank you, sir.
Thank you. Over to Dr. Prabhakar, sir. Many patients are telling low BP like that. High BP is there, low BP. J curve. And patients with the target organ damage, patient with the heart failure. What is the lowest BP you will target? With the target organ damage, without target organ damage, with heart failure, and without heart failure. Over to Dr. Prabhakar, sir.
So this is actually a very tricky question because there are multiple questions added in this. One is that if you look at patients with target organ damage, without target organ damage, we say that we start antihypertensive therapy, we start talking about 140/90, but the general target for treatment is going to be 130/80. I would like to listen to Dr. Ramakrishnan also subsequently on this. But when you have a left ventricular hypertrophy, you target it a little lower to about 120/80 also, because that is when we say that reversal of left ventricular hypertrophy can happen. Now, if you start treating patients with target organ damage, like say, for instance, if you're having a coronary artery disease, especially in the elderly, you don't bring down the blood pressure less than 120/70 because there is going to be reduced perfusion. So you try to keep a target of 120/70 plus in these patients. Don't try to bring it down less than this, especially when there is an ischemic heart disease underlying in these patients. When it comes to heart failure, it's an even totally different ballgame because you have to treat the patients mostly with 4 basic drugs. One is going to be the ARNI or the RAS inhibition. 2 is going to be the beta blockers. 3 is going to be the SGLT2 inhibitors. And 4 is going to be the MRA or the spironolactone. And when you start treating all 4 drugs, all 4 will bring down the blood pressure. You have to be careful choosing, but get all 4 drugs on board. Important thing that to remember is it is not the absolute value of blood pressure alone, but symptomatic hypotension matters. If a patient tolerates 90/70, walking around comfortable without any problem, taking all 4 drugs, I would leave the patient alone. This is the target going to be in heart failure. Hypertensive heart failure, where the blood pressures are high, is very easy to treat because you can bring down the BP comfortably very well. Dr. Ramakrishnan, sir, I would like your opinion also on this.
I think I would agree. I would agree with whatever you're saying, but possibly I think we are not treating to target in a heart failure patient. Like primarily, we are treating to increase the dose of antihypertensive medications to an optimal level, and where I think possibly Indian physicians do a disservice to the patients, because I think of all the treatment that we do, possibly the best NNT, best number needed to treat to prevent a death is with beta blockers in heart failure. So somehow we underuse it and underdose it, and oftentimes we stop when the blood pressure comes to around 100/60. But we just can go on, and you don't have to bother. Symptomatic hypotension is the one that is serious, and rest of the times even 90/60 is good enough for a heart failure patient.
Yeah, especially in
We are not,
ICU
there is no target.
MI
There is no
patient.
target. Yeah.
Yeah, especially the MI patient first 3 days in ICU, urine output is normal, adequate, and mental orientation is adequate, no jaundice, no other target organ damage, but the BP is 80/60 or 90/60, whether to bother or whether to give noradrenaline drip also to improve the BP. Over to Radha.
No, absolutely no, because it's all tissue perfusion that we are targeting. Like there is a definition for shock, and that definition can be easily followed. And it is when there is shock, then you treat shock. Don't treat the blood pressure like.
Yeah. Over to Dr. Ramakrishnan. Diabetes is CHT equivalent. Do you agree?
I think Dr. Mohan also pointed out. I think diabetes is definitely not an equivalent to CHD, provided you are able to keep your HbA1c in control, you are able to keep your blood pressure in control, and keep a tab on your exercise, diet, as well as your cholesterol level, LDL levels. So generally, even though initial guidelines suggested it is, but most of the now data suggests that it is actually not a CHD equivalent. Only thing is that possibly they all will qualify for a statin therapy. That is the only thing. Above 40, they all
in a modified manner. I would like to add.
Sir, I have a question to ask here, sir. Very relevant question.
Yes, sir.
Because this issue was raised, I was waiting for the question, Dr. Palniappan, sir. Just allow me to ask this question. Many diabetologists in our place and many other physicians I see, when a patient is diagnosed with diabetes, they say it is CHD equivalent and start them on antiplatelet therapy. And I want to know the justification for this, and what do you do with such patients? Do you continue or you stop? Just I would like to know the audience view in this, sir.
One important modification, Dr. Ramakrishnan, actually, when the diagnosis is type 2 diabetes mellitus, 50% of the patient, they are associated with the target organ damage already. So these patients can be called as a coronary artery heart disease equivalent. But 50% of the patient, they are not having even a single target organ damage. If that patient, if you target properly, you can improve the longevity, definitely. So 50% at the time of diagnosis, no target organ damage. 50% they are not at all having any target organ damage. You are picking up the type 2 diabetes mellitus very early. So nowadays, this is very common. So nowadays, we can call it as it's not a CHD equivalent, but previously it is equivalent. That is absolutely true. What's your opinion, Dr. Professor Mohan, sir?
Yeah. So we all know from Stephen Hafner's work that the clock for macrovascular disease starts ticking at the stage of pre-diabetes, whereas for microvascular disease, it only starts after diabetes. That's where the distinction between pre-diabetes and diabetes came. So as far as the macrovascular complication are concerned, the risk actually starts at pre-diabetes, and therefore you can have more CVD and all that, even at the stage of pre-diabetes. Having said that, we know that type 2 diabetes is a very heterogeneous disease. So we can't lump everybody in the same basket and say everybody will develop heart disease, everybody will develop. So there are either genetically or because of phenotypically, there are huge differences. We have recently described 4 clusters. For example, type 2 diabetes can have the only severe insulin deficient variety, or only insulin resistant variety, or a combined variety for the first time we described in South Asian, and a mild age-related variety. That age-related variety, nothing is going to happen to them. They're going to get diabetes after 60, 70, they'll live up to 100, nothing will happen to them. But the other 3 groups, the SID variety, the insulin deficient variety, will develop more of retinopathy and neuropathy. Whereas the insulin resistant ones, they are the ones who will develop heart disease. So within type 2 diabetes, you'll have to make a distinction, and you cannot treat all type 2 diabetics and put them in the same basket.
So what do you do with the antiplatelets, sir? Supposing somebody has been started.
I don't think there is any role for primary prevention. Giving aspirin to everyone, you will make them bleed, and I think there's no role at all. Secondary prevention, yes, but primary prevention, I would definitely bring the lipids under control, keep the blood pressure under control if it's elevated, keep the sugars under good control. I don't give aspirin routinely to everyone. I think it's too.
And do you stop if someone has started, sir?
Difficult. That's a difficult one because somebody has started. How to stop now? It's always a difficult one. But better not to start because the risk of bleeding is too high. My own father needed 8 bottles of blood when he first started. There is a days when aspirin was first started. My brother-in-law had gone to US and said, "You must take statin. Everybody's taking aspirin. You have to take aspirin." He just took it for 3 weeks. Started bleeding so much. Dr. Madhanagopal had to give him 8 bottles of blood to keep him alive. We thought we were going to lose him. And ever since that, I said, no giving aspirin to everybody routinely like that. Just like he was perfectly all right. He simply started taking and started bleeding,
True, sir. Sir, our intensivist, when he came first and joined with us, an elderly man, he was on aspirin. When I spoke with him, he wasn't willing to give up on aspirin. Within 1 year, he gave up on aspirin because in our own unit, aspirin, hemorrhage, aspirin, hemorrhage. He got to see several patients. And now he is more than convinced. And now we have taken a policy that we speak with the person who has started. We ask the question, are you sure this patient has got ischemic heart disease? Don't tell me it's a diabetes and ischemic equivalent and I'm doing it. If you have ischemic heart disease, you have every valid reason to continue. I always inform the family and I take off all these patients from aspirin. So only statin, I leave them. Absolutely, I tell them statins are beneficial. I have no this one against it, but I have primary antiplatelets are to be absolutely, we have to take it away from our basket. That was my question, sir. I have another question regarding the discussion that was made, sir. There was a statement about the intriguing statement, I must say, about the physicality in yoga treatment. So I would like to know about the yoga and the physicality.
Later.
Yes, sir.
Yeah. Over to Dr. Prabhakar, sir. Rapid fire question: risk factors versus risk markers control to increase the longevity, sir, for the ASCVD.
First point is, what is a risk factor? What is a risk marker? Risk factor, causality is proven. Risk markers, association is proven. So if you look at risk markers, several kind of risk markers are there. 2 simple varieties of risk markers are the imaging markers and the circulatory markers. Imaging marker, coronary artery calcium score has come up in a big way. The other risk markers that they have found out today are the HSCRP, very, very significantly found out. Oxidized LDL also has been proven to be a risk marker. And lipoprotein little a, I think, is moving more towards a risk factor because now we are talking about lipoprotein little a as a risk factor. And the other thing that is recently catching up is the highly sensitive troponin as a risk marker, because even in the normal people, elevated highly sensitive troponin has been found to be a risk marker. Risk factors have to be controlled. Risk markers can be controlled, and they guide you in the treatment. That I think can be the simplest quick track answer or a fast track answer I can give you.
Yeah, thank you, Dr. Prabhakaran. Sir, over to Dr. Ramakrishnan. Medical treatment versus PCI, especially MI, that is 6 hours old or 1 day old, in the periphery center without cath lab, rescue PCI, all those things. There are a lot of terminologies are coming. So after 3 days or 5 days, that is rescue PCI is superior on compared to medical treatment. Nowadays, recent trials has come, both medical and PCIs are equally good. What is your opinion regarding this, especially with the old patient?
I think let us not confuse the issue. There are three patients are there. One is a patient with STEMI, that is ST elevation myocardial infarction. Another one is a patient with ACS, that is non-ST elevation MI or unstable angina. And another one is a patient with chronic coronary syndrome. So there are 3 likely possibilities in which a patient this question can arise. So let's first talk about STEMI. STEMI, anybody coming within say 12 hours or 24 hours with ongoing chest pain and ST elevation, clear cut, you take them to lab if it is available. And that's a class 1 recommendation, possibly the best PCI where you can actually save more lives than what you can do. Because otherwise the disease is killing. So PCI save the artery anyway. But the problem is if the disease is killing, then you save lives with the PCI also. So then next question is, a patient is thrombolized with STEMI. So what will you do? If you thrombolized with STEMI within 3 to 24 hours, if you are able to do a PCI, then it is also life-saving. If you are not able to do, possibly within 48 hours, if you are able to do, it is better to do. But if the patient is hemodynamically unstable, electrical instability is there, patient having recurrent chest pain or having heart failure, then you should do a PCI. And in rest of the patients, if it is beyond 72 hours, there is clear evidence that routine PCI may be harmful, and it's better to do a stress evaluation followed by a PCI. Coming to unstable angina or NSTEMI, it is better to stick to what is classically described as gray score. You follow a gray score, and if its gray score is more than 140, you take them to an early invasive strategy. If it is less, it's a very simple. You can calculate it easily in your smartphone. It's no big deal. So you just have to, your sister can fill it up and tell you what is the grade score of the patient. But the chronic coronary syndrome, there is a problem. Majority of the patients can be kept on medical follow-up, and only when the angina is not controlled, then you can go for angina with the PCI. Or if the patient has a significant left main or a TVD, then possibly revascularization is a must. Or if the patient is recurrent symptomatic is there, then you can take them off for angiography. Or if there are high-risk features on stress testing, then also you can take them for revascularization strategy. So I think this is in a nutshell the whole of coronary cardiology for you in intervention.
Role of ARNI in peri-COVID heart failure, Dr. Ramakrishnan.
I think so first question is it a de novo heart failure, or is it a new onset heart failure, or is it a already existing heart failure? If it is an already existing heart failure, existing heart failure is, I think there is no point in stopping it also if the patient is on ARNI, unless your hypertension was the reason for stopping it. So otherwise you should have continued ARNI or continued ACE inhibitor if the patient is already on. If the patient is already on ACE inhibitor, I think if there is no AKI or no hyperkalemia, I think you should better continue, because stopping medications have been shown to be more harmful in heart failure situations than continuation of heart failure in most of the acute decompensation phases, which would include even COVID also.
One point I'd like to add in the ARB controversy, sir. Actually, what happens if you are already on ARBs and if you develop COVID and serious COVID, ARBs have been found to be useful. They actually benefit from ARBs. Yes. So there's no question of stopping ARBs.
Suggestion of benefit also. So there is no point of stopping. If already patient is on, I would continue. If the patient is not on, then I may not start ARNI. If the patient is on ACE inhibitor, I will continue ACE inhibitor or whatever he is on.
Yeah. Over to Professor Dr. S. N. Narsingan, sir. Newly detected type 2 diabetes mellitus and hypertension, but lipid profile is normal at the age of 25 years. Will you start them on statin, sir? All diabetic patients, even newly detected diabetes mellitus, even the lipid profile is normal or near normal. Will you start them on all the type 2 diabetes mellitus? Will you start them on statin, sir?
In fact, in our country, because of the problems that we are witnessing, the increasing epidemic of diabetes, and more younger people are affected with the diabetes, more younger people with the diabetes are succumbing to coronary artery disease. It is, I think, it is strongly recommended by Lipid Association of India. The moment you make a diagnosis of type 2 diabetes in an individual, you need to put the patient on statin. And moreover, you also mentioned that the patient is also a hypertensive. Diabetic and hypertensive, one more risk factor is also operating in the equal. The age is only 29 years old, that's what you mentioned. But a 29-year-old fellow with diabetes and hypertension must be suffering from probably other risk factors, other constellation of risk factors may be coming under metabolic syndrome with the diabetes. I think we are justified in giving him the benefit of statin therapy in that individual. In our Lipid Association of India recommends that all patients with the diabetes, the moment you make a diagnosis of diabetes, you need to put the patient on statin therapy. This is what we differ from the ADA recommendation.
Sir, the important point there is, what is that normal that you're talking about? That is not defined.
Which one? Which one?
No, the normal, he said normal lipid profile. What does he mean by normal lipid profile? The number you're looking at is also important.
Yeah.
70, LDL 70.
Yes, sir. Less than 70 is a very tricky area to start statin, sir. Even in this subgroup.
Over to Dr. Raman Puri, sir. Professor Dr. Raman Puri, sir. My uncle had a first, that is PCI for a lady at the age of 55 years. And 65 years, he had a second attack. Patient, he's on rosuvastatin 20 milligram diabetes controlled with OAD with the insulin, and on fenofibrate for hypertriglyceridemia, still the LDL cholesterol is 90, but LA guidelines, it says there is extreme high risk class B individual. Here LDL goal is less than 30. Sir used to say, so maximum tolerable dose of rosuvastatin was given. On top of that, estimate also tried, and fenofibrate is also tried. Will you add, that is omega-3 fatty acid, or recently there are a lot of there is prominent trial, is ongoing trial. Will you add omega-3 fatty acid as well as that is pemafibrate also in this patient, sir, to increase the longevity to 100, sir?
Now, if we look into the lipid profile of this patient and the ASCVD risk category, he falls into ASCVD risk category B, extreme risk group category B. And as you have said, the LDL cholesterol target has to be less than 30 milligram at least. Now, his LDL cholesterol is 90, and he is already on high intensity statin plus azetamide. Instead of adding fibrate to this patient, we should add PCSK9 inhibitor, because we have not achieved LDL cholesterol target so far. And the most important target for us, the primary target, is LDL cholesterol target. Fenofibrate may reduce LDL cholesterol slightly, but not significantly. And PCSK9 can reduce it by 60%. So from 90, we'll bring it down to 30 milligram per deciliter, comfortably with PCSK9 inhibitor. Even bempedoic acid may not work in this category because it reduces LDL cholesterol by another 15 to 20%. So I think that in case PCSK9 is available and patient can afford, I think this will be a drug which should be used in his case to bring down LDL cholesterol. Fibrate and omega fatty acid role comes only when the triglyceride is raised and you have already achieved LDL cholesterol target. And omega fatty acid has been recently, come into the limelight because of reduced trial in which icosapent ethyl in 4 gram has shown reduction in total mortality and CVD mortality equivalent to what statin did about 3 decades before. So if these patients of extreme risk group category B patients have high triglyceride and high non-HDL cholesterol, then definitely in Indian scenario, we should add first fenofibrate, and if it is not able to control, then we should add omega fatty acid. But if you add PCSK9 to achieve LDL cholesterol, in majority of patients, since PCSK9 inhibitor reduces non-HDL cholesterol by 48%, we'll be able to achieve all the targets of what is required, LDL cholesterol target and non-HDL cholesterol target. And of course, if ApoB assessment is done, probably we'll achieve ApoB level also in this group of patients. So our most important drug will be PCSK9 inhibitor.
Sir, when the setting of reducing the triglyceride cholesterol, will you select whether the fenofibrate or omega-3 fatty acid, sir?
See,
which is best drug?
I think the triglyceride role only comes if it is more than 500. If it is more than 500, because our priority is to reduce pancreatitis and we have to bring down triglyceride. Triglyceride below 500, let us not look at triglyceride, look into non-HDL cholesterol. Because once you control non-HDL cholesterol, triglyceride will come down automatically. So in Indian scenario, fibrate is an important drug because it is very less, its cost is very less, it is not expensive. And icosapent ethyl ester, if it comes into the market, probably will be very expensive drug. And there had been some controversy regarding results of icosapent ethyl because the mineral oil which they used probably might have increased the risk in those patients, events in those patients. So comparison, we got better results with icosapent ethyl ester. Till the results are very clear, I think fenofibrate will still remain a drug of choice.
Sir, what is your opinion? There is a residual risk also there that is after treating, that is primary goal LDL and co-primary non-HDL and triglycerides goal, that is a secondary goal. After that, still you are having a residual risk. After putting them on PCSK9 inhibitor, still ApoB is high, lipoprotein small a is high. what is the drug of choice, sir? This will PCSK will take care of all these residual risks, or you have to add some more drugs, sir?
I think to simplify all this, in patients of the patient, you should always look for LDL cholesterol target, achieve it, then look for non-HDL cholesterol target and try to achieve with various combination of drug. Of course, statin remains the most important drug. And even in Fourier trial, in which the mean LDL cholesterol achieved was, median LDL cholesterol achieved was 30 milligram, even then 12.5% of these patients had events. So these events may be because of higher ApoB or higher non-HDL cholesterol or lipoprotein small a, or because of other metabolic or thrombotic factors might be responsible for CV events. But of course, once you have achieved LDL cholesterol target and non-HDL cholesterol target, ApoB becomes very important. In our recent expert consensus statement, which we have published last year, we have we have emphasized on the importance of ApoB, and we have included ApoB as a moderate risk non-conventional risk factor also, but we have recommended ApoB, especially in patients with diabetes and patients with metabolic syndrome and those patients with extreme risk category B. The importance of ApoB in such scenario is that if there is a discordance between non-HDL cholesterol and ApoB, means non-HDL cholesterol is normal, means you have achieved the target, and ApoB is still high, then you have to treat this patient aggressively because you have to bring down the ApoB level to the target. We have given target of ApoB at different level of non-HDL cholesterol and LDL cholesterol. And if it is discordant in other way, means non-HDL cholesterol is high, but you have achieved ApoB target, then you don't have to be aggressive in bringing down non-HDL cholesterol to the target. Probably all these particles like VLDL remnant and IDL and LDL cholesterol particles are larger particle. Probably they will not contribute to atherosclerosis because it is large particle doesn't crosses subintimal space. Therefore, we have you should go for ApoB assessment, especially in these patients who are diabetic with target organ damage and extreme risk group, and try to achieve target. Once you achieve LDL cholesterol target and non-HDL cholesterol target and ApoB, you have done your job. Then comes role of lipoprotein small a, which is important because 25 to 30% of Indian population have higher values of lipoprotein small a. And if it is more than 50 milligram, even if patient doesnn't have any ASCVD risk factor, no other risk factor at even age 20, this patient falls into high risk group where the target of LDL cholesterol has to be less than 70 milligram. And PCSK9 plays an important role because there is no other drug. Even statin increases lipoprotein A by 5 to 10%. It is only PCSK9 which reduces it by about 20 to 25%. It still is a controversial statement because it is not still proved that whether PCSK9 really brings down lipoprotein A to such a value of 50 to 20 to 25%. But however, if lipoprotein A is raised, PCSK9 plays an important because lipoprotein is atherogenic and it definitely increases cardiovascular event in patients with the coronary artery disease or those patients who are prone to have cardiovascular events.
A rapid fire question to Dr. S.N. Nursing and Professor. What is the target triglyceride cholesterol in post-PCI patients, sir? And another question is, to increase the HDL cholesterol, alcohol exercise will increase the HDL cholesterol. Really, is there a drug? Really, do you want to increase the HDL cholesterol even after LDL reduction, non-HDL reduction, triglycerides reduction, sir? Do you want to increase HDL cholesterol also with the drug, sir?
The thing is, the first question is that post-PCI, we have already reached the levels of LDL cholesterol. The triglyceride levels are high. That's what you meant. If it is raised and if it is more than 500, if it is more than 500, probably you need to think about all secondary causes for hypertriglyceridemia in that individual. Try to rule it out, including hypothyroid state or obesity or increased consumption of carbohydrates. So many factors are probably operating. You need to identify that and rectify it. Good glucose control in a patient with diabetes, you need to make it. So bring down the triglyceride level. In case the patient is not responding, still their triglyceride levels are raised. It is 200 to 500. Then there is an increase in probably a cardiovascular risk. In that situation, if you had already given high dose statin, with acetamide, and probably one can choose the other drugs, particularly the reduced trial has shown the efficacy of icosapent ester. If it is going to be available in our country, probably that may be the good drug of choice. In other words, probably one can use omega-3 fatty acids, what is available in our country, but many people may not tolerate the 4-gram dose, which is recommended, which is not tolerated by our patients. So there is no need to use that. Fenofibrate probably will help with those individuals in whom you have between 200 to 500 milligrams of triglyceride, and you have ruled out all secondary causes. Still, the triglycerides are raised. That means you need to put the patient on a fibrate. Fibrate usage, again, based on the meta-analysis, which had proved that the people who have shown higher levels of triglycerides, more than 204 milligrams, and shown a benefit of reduction of 35% risk in CV risk. So we can use fenofibrate in such situations. Of course, the fenofibrate trial is going on. If it,
less than 100 or 150, sir? Target TGL, sir.
The target TGL should be less than 150, and it is optional to keep it around 100. That is a recommendation given by Lipid Association of India. And the other one, what you have asked is about HDL cholesterol. HDL cholesterol, I think we can only increase the HDL cholesterol only by exercise, and that too it should be a vigorous exercise and should be for a period of 1 to 2 years. Only then it is possible to increase the HDL cholesterol. If you bring down the triglyceride levels, normally the HDL cholesterol will also go up. If you stop smoking, probably the HDL cholesterol levels will go up. There are only certain lifestyle modifications which need to be probably implemented so that you can get a benefit of increasing the HDL cholesterol. No drug so far has been identified to improve the HDL cholesterol. None of the trials have shown a benefit of increasing the HDL cholesterol, though the numbers had gone up in many trials, including the AMI trial or HPS2 study, which had not shown any sort of benefit either with nicotinic acid or with the CETP inhibitors like anacetrapib, dalcetrapib, or torcetrapib. All these trials have failed to show any benefit in the cardiovascular outcome by increasing the HDL cholesterol. So today, we don't have any weapon to increase the HDL other than regular exercise and then strict lifestyle modification. Good amount of exercise is the benefit that we probably can achieve.
I think I just want to add a small point here that I think I agree with whatever Sir has said. Only thing is HDL is not a one molecule. Like it's like there are so many functional units, and now we are beginning to understand it much better. So possibly what we measure as HDL may not be one thing. Like that is why where drugs were used to raise it also, we are not actually raising what we want to be raised. Like
one added point, sir, to whatever you added. What we measure as HDL cholesterol is only the content of the cholesterol. We don't measure the functionality of the HDL cholesterol, which is supposed to do the reverse cholesterol transport. So if you are going to do that, that is not possible in clinical practice. So that is why HDL cholesterol, raising it with drugs like the nicotinic acid and the anacetrapib drugs, they did not benefit because it brought it up, but the functionality was not proved. Right. So looking at HDL cholesterol number per se is not beneficial. Functionality is not there. The functionality improves only by physiological methods.
Functional HDL particles, dysfunctional HDL particles. Yes.
Over to Dr. Senthil Velan. Work-life imbalance is lot of things is going on. I have lost 4 important doctors, my classmates, Dr. Sargunan due to alcohol dependence, and Dr. Anand also alcohol dependence and coral, all those things. And Rajesh Kumar, he also died due to family problem. Dr. Raghu also died due to alcohol and family problem. There are a lot of things are going on. To be a successful person, you have to live for more than expected, the more 200 years without any quarrel, and quality of life also very important. To be a successful person, the scientific knowledge is only 20% plays a role, 40% emotional skills and 40% social skill. This is the formula usually. How will you balance work-life balance? Please give 2-3 minutes advice to all the doctors also. Senthil Velan.
Unmute.
Sorry. Frankly speaking, doctors like us don't have the luxury to balance the work and our life roles. Actually, what is happening in our life is that we are bound to work for the society. it is actually not for earning money. It is inbuilt in our body and mind that we are for the society. So what happens in our society? We doctors, we work for so many hours. Say for example, I am running a hospital, you are running a hospital. We are seeing 50 to 60 OPs per day. We are taking care of 20 to 25 inpatients, and sometimes we'll be having 5 to 10 patients in the ICU. Then how can you prepare some time to spend with your family? So it's too difficult. So the question is that in our setup, we have to change our minds. That first thing, we have to delegate our responsibilities and duties to some other persons. So we have to keep some helping persons like assistants, so that we can delegate our works and our duties to them. But what happens in our mind is that most of the time we are all workaholics, and we'll be having a perfectionism in our mind, so that we don't allow, or we don't rely upon, or we don't believe in the work quality of others, so that we want to do everything on our own, so that we'll be working very hard from the day starts till it's midnight. So we will be losing the quality time to spend with our children, spend with our family members, our relatives, and social integrations. So one survey tells that, one psychological survey tells that the important factors that will increase the longevity. So starting from the bottom, it's the clean air, it's the food, good food habits, and it's doing yoga, meditation, and without hypertension, without diabetes, without alcohol, without tobacco, doing everything perfect in your life. These are all comes under two things. The top of the table is that your social interaction that makes you to live longer. That's what they told about that blue zone activities, that people are living that in that area, and how they live beyond 100 years of age. So the social interaction is very, very important. And the second thing is that you should have close relationship to whom you can share your feelings, whom you can ventilate your feelings, and to whom you can seek help whenever needed. So this is the very important thing. The two important things are the social interaction and your close relationships. These are all the two things that can increase the longevity of human beings. But in case of doctor's life, and doctors like that too in India, this is the problem. So we are not having adequate time. So the first thing we have to do, that we have to go out of our perfectionism. We have to rely upon our subordinates. We have to delegate works, and we have to switch off our phones at least after 10 o'clock. For that, we have to maintain a separate doctors during the night hours. So like in UK, people are, our friends, the doctors, they are seeing 5 to 10 cases per day, 4 days in a week. And they will have an on-call per week, 1 day per week. And what happens to our life? We'll be working all the day. We'll be on call all the day. So how can we spend quality time with our family members? So this is the problem. So we have to reduce the caseload, then only we can perform the roles of our life in a perfect way. So we have to balance the work as well as our life roles, and we have to accomplish both the roles without one disturbing or having an adverse effect on the other role. For that, so we have to go out of our perfectionism. We have to delegate other people. We have to believe in other people. We have to go out of communication at some time in a day to be happy with our family. And you should have passions, and you should have separate career other than this medical profession. These are all very important things to balance your work and life and to live longer. Thank you.
Can I make a comment, Palaniappan? Is it possible now? 1 minute comment only. Dr. Shibendu here.
Yeah, half a minute, quickly.
Yeah, very quickly. So
Yes,
the last of the doctors, to have more money, more power, more, what I said, to more honor. That is one of the problem in the society of the doctors. And we are separate from the US and UK people. We do not think that we have got a better lifestyle. We can have a better lifestyle. We do not control our patient population. We do not control our activities. It is on us. We have to do this practice almost now, today onwards. Otherwise, you cannot control. That is my only suggestion for all doctors. Thank you very much.
Yes, sir. Rajesh Upadhyay, sir.
Can I make a comment as well? I
Yes, sir.
entirely agree. I think the onus lies on us, the doctors. We have to decide the way we want to live. I have worked for 10 years in UK and remaining of my time here. And I can tell you, you just have to change your mindset. There is an underlying greed. I'm sorry to say that. But somewhere we want to either have the money or the respect or the gratitude of our patients that we keep on doing it. Mind you, Dr. Palniappan, this whole program is about secrets of living for 100 years. Fine. Now, any disease treatment or achieving targets will give you a few more years, maybe 5, 10, 15. But this is not the secret of living for 100 years. The secret for living is actually healthy aging. Healthy aging, because that defines the quality. So if we are really talking about that, I think 4 things which the previous doctor has already talked about is, and we cannot, prevention, prevent disease by lifestyle changes. What are the changes? Well, we all know, but we don't practice. Diet, and your dietitian and nutritionist gave a very nice description of how vegetarian diets and the diets which they follow in blue zones, etc. And I will not like to go into detail. Exercise, diet followed by exercise, followed by your family socializing, followed by your community socializing, and followed by that spirituality in you. All this requires time, but we have to find it for ourselves. Nobody else is going to give it to you. So each one of us is responsible for the way we lead our life. We cannot blame, and I know we discuss treatment of disease, which is fine because we are doctors, we always talk about disease. But I think living 100 years is all about prevention. Prevent disease and promote health.
Last question to Dr. Ramakrishnan. Important tricky question. Actually, the many patients with hold or ACS patient, they are coming. Shall I take COVID vaccination? I usually advise when you are on any drug, anti-hypertensive drug, antiplatelet drug, any post-MI patient, stent patient, dual antiplatelet drug, or AC, or on top of all the drug, you continue the same. On top of the drug only, you have to take the vaccination. Without skipping the drugs for 1 week will precipitate MI. So you have to be on all the prescribed drug you should be. Many patients, they will be actually chances of getting, because of stress and strain, not done more than 40 years, not done TMT, other things, 256 CT angio, multiple risk factors. With all the tests are done, and on top of that, all the adequate drugs, if they are on, means definitely they should go for a vaccination. This is my usual advice, because COVID is a pro-coagulant also, COVID vaccination also. What is your modified advice, Professor Dr. Ramakrishnan, sir?
So I think the advice is simply whatever is drugs they are taking, and they should take the vaccine as early as possible. And I think for doctors also, many of the doctors also, there is a lot of concern about the vaccination with DAPT and all. I think for ages we have given injection Penidur, which is actually a very painful and bigger needle injection in all patients who have had a valve replacement. I think for ages, every cardiologist who have practiced would have given it in post valve replacement. Penidur injection is given, like. So I think we have given it for ages. Nothing happens in a gluteal region. Nothing happens. Like, I don't know why this suddenly, because of WhatsApp and everything, this DAPT with this small injection has become such a big thing, big issue. I think they should continue, and I think, but I would feel unless there is a primary indication for starting an aspirin, nobody should be started on an antiplatelet agent before they get their vaccine done, unless there is a priori reason for starting an aspirin. For example, patient had a old MI, he was not on aspirin, he should be started on aspirin. Anyway, he has to be started on aspirin before vaccination or whatever be despite vaccination. But if somebody doesn't need a aspirin, he must not be started on aspirin just because he is going for a vaccination.
Yeah, over to moderators, Dr. Y.P. Munjal sir, Dr. N.P. Singh, Dr. Girish Mathur, Dr. Jyotirmay Paul, for a final conclusion.
Sir, one
this
question,
topic,
sir. One half a minute. One question, half a minute.
Yeah, please.
Sir, what exercise can we do post-COVID?
Post-COVID aerobic exercise or a resistant exercise or flexible exercise depends upon the patient, depends upon the post-MI, all depends upon whether the patient is having heart failure or renal failure, all those things, definitely flexibility exercise. All other fit patient, definitely aerobic exercise as well as resistant exercise if possible. And that is a diabetic retinopathy patient, definitely flexibility exercise is too good. Sir, over to moderator, sir, Y.P. Munjal, sir, and N.P. Singh, sir, and Girish Mathur and Jyotirmay Paul, sir, to conclude the final remarks, sir. Sir? Dr. N.P. Singh, Girish Mathur and Jyotirmay Paul. Yes, sir. Yes, sir. Sir, may I ask Dr. Professor Dr. S.N. Narsingan, sir, to give a final remark, sir.
Unmute you.
Unmute, sir.
Sir, unmute, please. Sir, unmute, please.
I think all the senior people who are the key speakers as well as the key persons involved in APA had probably left for their sleep. Only Pranayama is awake all the time. And he has now given me an opportunity to talk to you at the end. Again, I'm telling you, this is a wonderful program. And he has involved many senior people here. And with us, all specialists also involved in this particular program, which I'm sure will pave the way for all of us to practice in such a way that we will live for long period till 100 years of our age. At the same time, we will also try to implement the same principles of living for a longer period to our patients all the time when the patient seeks advice in our clinic or a chapter. Thank you very much. Thank you, Dr. Pranayama.
I think laughter is a very important key thing for living longer. So I want to make one comment. I think following all this, Dr. Pranayama is going to live for 100 years. I want you to guess how many programs he is going to create. Maybe 10,000?
One thing that I have learned from Dr. Bhargava from ICMR, when I was just with him for another meeting, he told, if you like to live for 80 years of your age, you need to keep your LDL cholesterol less than 80. Your pulse rate must be less than 80. You need to walk for a period of 80 minutes, 3 days in session and 1 day rest in between. Again, 80 minutes for 3 days in the week. Only 1 day in between rest. And then you try to be 80 meters away from your smoker. And then keep the diastolic blood pressure around 80. You will live for 80 years.
Probably add 80 ml of alcohol, sir, per week.
Thank you very much, sir.
Thank you.
Participation, sir. Munjal, sir, Singh and Mathur and Jyotirmay Paul, and Dr. Raman Puri, sir, Professor Narsingan, sir, Dr. Professor Mohan, sir, Rajesh Upadhyay, sir, Ramakrishnan, sir, and Prabhakaran, sir, Kumaravel, sir, and Subramaniam, and Senthil Velan, and Chandran, sir.
Yeah. Thank you. Thank you very much.
Thank you. Thank you.
Thank you so much, sir, for participating. Thank you.
Good night. Thank you.
Thank you. Thank you, Paliyappan.